David, you going to lead that or?
We have the United Healthcare team on. They're going to spend the next period just really going over plan performance review to compare, how the plan is performing, areas of opportunities for improvement, where things are working, and then that'll kind of lead into the discussion we're going to have as we transition to the budget piece. So that's the primary focus now is primarily healthcare. And I know Matt and Lori is on. Next period is really going over plan performance to compare how the plan is performing, areas of opportunities for improvement, where things are working, and then that will kind of lead into the discussion we're going to have as we transition to the budget piece. The primary focus now is primarily healthcare. So Matt and Lori is on. Next period is really going over the plan.
Really difficult to hear.
How the plan is performing, areas of opportunities for improvement, where things are working, and then that will kind of lead into the discussion we're going to have as we transition to the budget piece.
Something's up with David's audio. It's like it's looping or something.
Yeah, I stopped talking a minute ago. Can you hear me? Jay, I see you. Can you hear me now as I'm speaking?
I can hear you fine now.
Okay, yeah, I stopped speaking a minute ago and I was looping, as Mr. Long said.
Yeah, did you ask it?
It would help too if anyone who's not talking is on mute.
Hello?
Okay. David, are you there?
I'm here. How about, can you hear me now, Jay? I can see you.
Yep.
Okay, perfect. Now, Matt from UHC.
Great. Can everybody hear me?
Yes.
Okay, fantastic. Well, first off, we want to start off by thanking you for your time today. We think this meeting is really valuable for us to take a look at your recent claim experience and especially look at the clinical cost drivers, because that will help inform some of our decisions moving forward in both plan design, but then also ways that we can help serve your members better so that they can get the care that they need. We have a ton of UHC folks on the line. We brought in experts from our clinical, financial, and pharmacy management teams to answer any questions that you have. This is kind of a different environment for us, so it's hard to have a good conversation over video, but if you have questions throughout the meeting, please don't hesitate to stop us and ask. We want this to be more of a conversation. With that, we'll talk a little bit about the medical component, and then we'll work into a discussion about pharmacy. And Tanya Hott has taken the lead on working with Amy and our pharmacy team on the information. So I'll turn it over to her for kind of introductory comments on the actual presentation.
Good morning, everyone. As Matt said, thank you so much for taking the time to join us. Shelley, will you be sharing the presentation, or would you like me?
Tanya, if you could share.
Discussion about pharmacy. And
I believe
Tanya Hott has taken the lead on working with Amy.
Okay. Is everyone able to see the presentation?
We can.
Okay, great.
Yes.
Thank you so much.
Was this posted online, or is this something that we don't have currently? I know that the UHC presentation, due to the proprietary information, was something that Shelley had emailed out, I think late on Friday, if I'm not mistaken. Yes, that's correct.
Is everyone able to see the presentation?
Yes. I'll have to go look for it. Thanks.
Okay, great. Thank you so much.
Was this posted online, or is this something that we don't have currently?
Commissioner, this part of the presentation was not
I know
posted
the UHC
online.
presentation. I'm not sure where the looping from. Shelley, it sounds like when Shelley's not muted, that's
what the problem. I don't know if that fixes it or not.
Okay. Well, I'll go ahead and move forward and get started since everyone can see the presentation. So here's our agenda for the healthcare portion. We'll have two separate decks to review today. We'll review the medical plan first, and then we'll transition over to review the pharmacy performance as well, with Jamar leading that presentation. As Matt mentioned, we do have quite a few team members from United Healthcare on the phone, our clinical experts to help answer any of your questions. Myself, Tanya Hott, I'm the Strategic Account Executive. Amy Heidbrink is with us, and she's our Health Analytic Consultant. She'll be leading the presentation to review your clinical data. We have Jamar Cote on the line with OptumRx, the pharmacy AE, and then Jack Drayford is joining us as well. He's our clinical consultant on the pharmacy side. We have Mark Koppenberg, Director of Affordability and Solutions on the Optum side, to talk about any questions you have about engagement with the clinical programs. We also have Carol Calvin joining us. She's our Vice President of Health Strategies. Extremely valuable input from her on the clinical side as well. We have Aaron Daniels with us today. I believe he spoke up earlier at the beginning, our Vice President of Sales and Account Management here in Central Texas. And then you all know Matt very well, our Director of Account Management. We don't have Laurie listed on here. I apologize, but she is joining us as well. She's our Field Account Manager, and she works very closely with your HR team in rolling out and discussing our various United Healthcare programs with your membership during open enrollment. So from a data parameter standpoint, we are reviewing the current period as compared to the prior period. So we'll be looking at calendar year 2019 with 2 months of run out through February 29th, 2020. Our claims experience with that run out is estimated at 97.9% complete. We do exclude Medicare primary members. And we also do look at a norm when we're looking at your benchmarks. We compare Williamson County to other Texas municipalities using a period of the most recent 12 months with 2 months of run out as well. From a catastrophic case threshold perspective, that denotes $50,000 in medical paid claims. And just a note that the data that we will review does not include any stop-loss reimbursements. So with that, we'll go ahead and move forward, and I'll go ahead and turn it over to Amy Heidbrink, and she'll kick it off for us.
Okay, thank you, Tanya. Can everyone hear me?
We can.
Okay, good. Just making sure. I'm not usually connected this way usually. Okay, starting here, just a look at your overall performance on the medical plan this year. Your overall trend was.
We'll go ahead and
Can we stop for just a moment? Rory's going to try to fix the looping issue.
Yeah, please do, Lori. Thanks.
Everybody mute their microphones right now.
Can everyone hear me? Okay, good. Just making sure. I'm not usually connected this way
Can
usually.
you stop for,
Okay,
hold on, give us 5
starting here,
minutes.
just
Hold
a
on,
look at
please.
your overall performance on the medical plan.
That's the looping, Sally.
Your overall trend was.
Can we stop for just a moment? Rory's going to try to fix the looping issue.
Everybody mute their microphones right now.
Everyone hear me? Just making sure. I'm not usually connected this way
Can you
usually.
stop for,
Okay,
hold on, give us 5 minutes. Hold on,
look at
please.
your overall performance on the medical
That's the
plan.
looping, Sally.
Your overall trend was.
Can we stop for just a moment? Rory's going to try to fix the looping issue.
Everybody mute their microphones right now. Can you mute yourself? Carol, can you hear me?
Are you asking us a question, Murray?
Yeah, I was asking if Carol can hear me.
With the treasurer's office.
Can you hear me?
Are you asking us a question, Murray?
I was asking if Carol can hear me. That's why. Okay, let's see if that's any better. If anybody is watching the YouTube stream, it's probably at least, I don't know, 45 seconds to a minute and a half behind everything. See if it comes back.
Okay, we think we're, so if we want to go ahead and maybe proceed with the presentation.
Okay. Can you guys hear me?
We can.
Okay, perfect. Okay. So starting on the plan performance summary, your medical trend this year was relatively flat. It just went up by 0.1%. You're at $337.39 paid per member per month. When we break that down into the catastrophic and your non-catastrophic, so the members below 50,000 net paid, that decreased by 7.7%. And your catastrophic spend, those members that had over 50,000 in claims, increased by 10.6%. You can see there the variance to the norm, and the norm that we used this year, it was Texas municipalities. So your overall trend or your overall paid PMPM this year is 18% below the norm.
Just a quick question. This is Cynthia Long, does that include, is that the total population, retirees and current employees and family and et cetera?
Yes, that's all of your members covered under the medical plan.
Thanks.
And you can see there to the bottom right, the average membership, which increased 4% year over year. So the dark blue is the most recent, the current period, and the light blue is the prior. So you had a 4% increase there. Your retrospective risk score, which is a measure of your claims risk over the past year, also increased by 4% over the prior year, but is still below the norm. And then the health continuum impact is a measure of how many members either stayed in the same general health category or improved their health. And you had a 79.5% health continuum there. Those numbers over to the left, your premium provider utilization was about 45%, just a half point decrease from where you were last year, but you're still doing 8 points better than the norm. And we'll take a closer look at that in here in a little while. Your clinical program engagement, you had 68% of your members that qualified for a clinical program that did engage, which is up 1.5 points from last year. And then your health activation score, which we'll talk about in more detail later, is a measure of members making the most optimal health care decisions. And so with all the decisions that we measure, you had almost a 76% optimal decision-making score there. And you can go to the next slide. Here, just looking at some of the additional components that made that led to your trend. Again, that trend was relatively flat from last year. As we look at your diagnosis categories and how those impacted that, you had a $16, almost $17 decrease in the amount paid per member per month for perinatal period. That's basically your premature babies and everything. So you had a high rate of, you had a lot of, you had, excuse me, a lot paid in the previous year, but had a significant decrease this year. Injuries and poisonings went up $11. Musculoskeletal related claims, that's like your back and joint pain, went up almost $9 per member per month. Circulatory system, which includes your heart disease, hypertension related claims, things like that, went up about $8. And then your nervous system related claims decreased $7 per member per month. Looking at the bottom, just your key performance indicators. Really, the two main things that stand out from this standpoint is your average paid per catastrophic case. That did increase by about 12%. And we'll take a little bit of a closer look here in a minute. Carol will discuss that. And then the very bottom line, your specialty pharmacy, that's the pharmacy portion, the specialty pharmacy that's paid under the medical plan, and that decreased by almost 29%. And then we can go to the next slide. Here we're looking at just a comparison of the members that are in your Nexus ACO plan compared to your Choice Plus plan. There at the top, you can see that your Nexus ACO had about 77% of the members, but only 67% of the amount paid, of your total net paid, compared to the Choice plan, which had 23% of your membership and 32% of your net paid. And really, as we look across all of these metrics, you can see that the Nexus ACO plan outperformed the Choice Plus plan. The Choice Plus plan had it did have a slightly higher risk score than the Nexus ACO plan, but even once we adjust that paid PM amount by the risk score, the Choice Plus plan still was costing more per member per month on an adjusted basis. You had slightly better network utilization in the Nexus ACO plan, better premium provider utilization. And then when we look at things like your inpatient days per 1,000 and ER visits per 1,000, the Choice Plus plan performed a little bit worse than the Nexus ACO plan. And on the next two slides, I'm going to turn it over to Carol for a few minutes to talk about the catastrophic claimants.
Are you muted?
Carol, are you there?
Muted.
Okay, well, I guess I'll go ahead and continue to talk about this then. Maybe Tanya, if you can try to ping Carol or something real quick and let her know, but I'll go ahead and continue with this. So looking at your catastrophic cases, on average, you had 12 non-catastrophic cases per 1,000, just a little bit below where you were last year, so 2.3% decrease, and significantly below that norm, 25% below the norm. When we just, as far as an actual just head count, that was 45 individuals that had claims in excess of 50,000. So even though you had a decrease in the prevalence of catastrophic claimants, the average amount paid per catastrophic claimant did increase by almost 19%. So that's what really drove that catastrophic portion of the medical trend this year. When we look at the percent of claims that were attributed to catastrophic cases, 47% of all of your medical paid was on these catastrophic members, and 43% of your behavioral health spend was on these members as well. Looking at the bottom left, just looking at the top four medical categories that where your catastrophic spend was, Really, if you look over to the far right column there, this is ordered in order of the claim spend in each category. So 31% of your claims for catastrophics were neoplasms, those are your cancers, 16% injury and poisonings, 11% on musculoskeletal, and 9%. The column to the left, members can have claims in more than one category, so those numbers will exceed 100% as we add those up. So, for instance, somebody could have a cancer but could also have back pain, so they could be in more than one category there. And then just to the far right, we'll talk more in detail about your catastrophic and about your clinical engagement in a little while, but 64% of your catastrophic claimants were engaged with the clinical program, and those members that were engaged accounted for 73% of your total catastrophic spend. Okay, on this page, we're looking at just a little bit more detail on the individual catastrophic claimants. 40% of those cases were employees, down from 52% in the prior year. 27% of your catastrophic claimants did have diabetes as well. We like to monitor that because, of course, diabetes can be a precursor to a lot of additional comorbidities and can complicate other conditions that exist. So we do monitor that. 4% of your catastrophics were new to the plan this year. Only 2% had no prior claims history, so one member there. 36% might have had claims, but they didn't have anything that would trigger an outreach from our clinical team in the prior year. 22% did have an elevated risk in the prior year, but were not catastrophic yet. And then you had 18% that had a chronic condition, but were still considered low risk. And then another 18% that were ongoing catastrophic cases from the prior year. And then looking at the bottom, we've just indicated the top 10. 4 of those top 10 are no longer on the plan as of December. You can see that those claimants 4, 5, 6, and 7 with the arrows next to them are no longer on the plan. And you can see that the total paid on these cases does include pharmacy as well as the medical. And you can see there the breakdown of how much of each one of those claimants was spent on pharmacy. Okay, the next slide. All right, I'm going to turn it over to our clinical team to discuss the next few slides.
Good morning, everybody. This is Mark. Can you hear me?
Yes.
Excellent. Okay. Well, I'm happy to be here to discuss a little bit about engagement with your members. I've got about 4 slides to talk about. I hope by the end that you'll have a good understanding of where we're at. This first slide here is really the focus, I think, or the takeaway is to understand how engagement affects overall well-being as kind of worked through by clinical gap closures. So this slide basically it shows that about little over 3,000 of your members qualified for outreach of both mailing and non-mailing type of clinical engagements. And of those, we had about just about 1,100 members that had touches. And by touches, we mean any type of communication, whether it's mailing or non-mailing. And then out of those, we had 301 members, or 25% of the members with touches, who had specific clinical touches. That's actual conversations with a nurse. It's in a way you can think of that as members that agreed to participate in a clinical program but had no gap closures. But the good news out of that is 206 of those members, or 68%, worked one-on-one with a nurse and had clinical gap closures. So that's a really good ratio, and that's up from prior. So I think we're heading in the right direction for clinical engagement. And as I mentioned, engagement is so tied to the health continuum distribution, which is the bottom portion of this slide. And that's what we really think about is what percentage of your members are well, what percentage of your members are at risk, chronic, and complex. That really helps us to decide, where you're at overall and the effect of engagement. And what we look for in that is minimal migration and stability. And overall, we've got some good stability with your group. The well category was previous 38%. It's currently 29%, so that's down a little bit, but that is not too bad. And you can see the other categories are very stable. So I'm thinking that our engagement with your members has been quite successful in helping them maintain their health. So any questions on that one? Okay, let's move on. So this slide is a drill down of that engagement and our outreach attempts. And it talks about, on the top left, telephonic engagement specifically. On the bottom, we're going to talk a little bit about mailings. And the right graph shows those programs that were most heavily utilized through the engagement process. So the first number I want you to look at is the 19%. So that's the percentage of your members who qualified specifically for telephonic outreach. And it represents 69% of paid. So of those 19% members, we had 31% on the very bottom there that were engaged, which is a match for last year and a match for norm. And again, engage means gap closures, members working with nurses to understand their healthcare plans and ensuring that they're doing whatever they can to stay healthy. Of a little bit of note is the unable to be reached. We had 43% of that. So that represents, let's see, about 286 members, which is 13% over prior. So that's up a little bit. That's kind of a concern, wondering why, what type of problems we're having reaching your members or what their reactions are. We call these things U-try. So what it means is our nurses will attempt 2 to 3 times to contact your members. We'll try different days, we'll try different times, whatever we can. And your members then, we leave a message for them. And if they don't answer, we'll send them what we call a U-try letter that explains, who we are, what we're doing, and how to contact us. So those 43% of the members we left messages for, and most of them decided they were not interested in our assistance, which is fine. But it does affect our ability to close clinical gaps, and it does have an effect on the health continuum that we talked a little bit about earlier.
A quick question. This is David with Holmes Barbie. Can you tell us how many of those calls just went unanswered?
You know what? I would have to look at that. I'd have to run a report, but I could definitely get that information for you. Great question.
Does the call come in as, say, from United Healthcare if it comes to your cell phone, or does it just say some 800 number? Can you describe that a little bit more?
Sure. It really depends on which carrier a person has, and the carrier then interprets the incoming number based on whatever algorithms they have. And then, so unfortunately, the number that's displayed for an incoming call, I think, is not always descriptive of the source.
So Mark, can I ask a question? So it looks like, although I think it's concerning that we went from 30% to 43% unable to be reached, we're still well below the norm. So more people answer the calls than your norm.
Absolutely, that's right.
So that, yeah, it's still interesting that we dropped that much, though 13% is pretty significant.
Right. And some of the things we can do about that, and some of my other Optum and UHC teammates can attest to this, is there's mailings that we can send out. There's email bursts that we can send out as just a reminder, again, of who we are and why we're calling. So that can have a very positive effect. But would you like me to try to get some information for you on the specifics of the unable to be reached?
I think it'd be helpful, because I think we've heard that the more engaged our folks are, the healthier they are. And if we're losing engagement, then might be interesting.
Oh, absolutely. I respect your interest, because it has a huge effect. As I pointed out, engagement is so valuable to your members. So let me get some information with that. We'll share, and we'll have a deeper conversation moving forward. So very good. We'll just talk a little bit about about our mailings, which, as I'd mentioned, is another great way to close gaps. It takes a little longer than a 2 or 3 phone conversations over a couple of weeks, but it does have an effect. And you can see some of the specifics. A total of 36% of your members receive clinical guidance through healthy notes, preventive reminders, and disease management. And out of those, we had over 500 individual clinical gap closures. So always happy to see those mailings working out. And another important way to engage your members. So we will continue that moving through. And then you can see too, it's pretty interesting up on top, the programs that your members were engaged in: general case management, treatment decision support, inpatient care advocacy. That's when our nurses reach out to your members while they're in the hospital and make sure they have everything they need, introduce themselves, and lay the groundwork for future interactions post-hospitalization discharge, disease management, and medication advice. So I think we can move on to the next. So this slide is a drill down of some of those specialty programs that you have. Advocate for Me, treatment decision support, we talked a little bit about that, and your maternity. So A for Me, we can see we had about 1,300 members that had interactions with our A for Me staff. Out of those, we had 334 clinical program referrals. In other words, the conversation was triaged to the point where our staff felt it would be a good opportunity for your members to engage with a nurse. Out of those 334, 108 of your members accepted, and 105 of those enrolled in clinical programs. So which would lead to engagement and gap closures. So A for Me is another great way to get some gap closures. Treatment decision support, pretty interesting stuff. We had 120 qualified members. That's up considerably from prior. 99 engaged members. And there's the top 5 topics that were discussed. And something I always like to see is preventive care guidelines for women came in at number 2. That's helping me understand that your members are really concerned about, being proactive about their health. The other thing about treatment decision support is part of it is when a member calls in and they have a question about where they should go to get the care that they need, we always like to ensure they're going to go to the right place at the right time. So if a person is thinking they need to go to an ER room, for instance, and the nurse triages the call and they realize, hey, this case would be better served at an outpatient clinic, then we shift the member to that lower level of care. And in this case, we had 15 members with shifts and all of them went to lower. Of course, that being said, if a member calls in and they're thinking just to make an appointment with their doctor 2 weeks down the road, but it seems like an emergent situation, our nurses will shift them to a higher treatment level also based on the need. So a pretty good program there. Maternity, we had 34 of your members that qualified to participate in the maternity support program. Of those, we had just 5 engaged. So kind of matches up a little bit with the UTRI that we've talked about for the general population. And that is down from the prior. So we had 31 deliveries, and of those members that had deliveries, we had just 2 engaged, and with the balance not engaged in the maternity support program. You can see the C-section rate is up a little bit from prior, and then it's pretty difficult to see delivery count rates. It talks about engaged low risk and high risk. But what's interesting too is out of those 31 deliveries, 0 were transferred to NICU. So that shows some very good health patterns with your members. So questions on that?
Are there any recommended strategies to improve engagement in category?
Well, I think one of the biggest things that I just love is, and that's the maternity app, which we've had for quite a while. And it's really a great process because the members don't really have to talk with a nurse. They can interact when they want to, and very convenient. And I've seen good luck with that. It's just a matter of, again, getting your members to understand it's there and utilize it.
It's concerning to me that our C-section rate went up so drastically. Is that a trend overall, or?
Well, I think it is a trend overall, but the other thing to consider is um, how local doctors, maternity doctors, what their level is for determining the need of a C-section, what the mother's anticipated healthcare needs might be driven by fear of natural childbirth. There's also a lot of different ways of how things are coded, um, varying degrees of is it coded as a C-section or not a C-section. So while I think that information is valuable, there's a lot of subjective information that goes into that.
Mark,
Yeah.
Mark, this is
Mhm.
Carol. Sorry to
Carol.
interrupt, and
No,
I'm
please.
sorry about the audio earlier. I would say your C-section rate is maybe a tiny bit above our norm. We typically see around a 35%, but I will say your C-section rate in the prior period was extremely low, so that's why it looks, unusually high, but it's really very close to norm.
Okay, thanks.
Uh-huh.
Thanks, Carol.
You bet.
Well, we can move on to the last but not least, just a couple more specialties to talk about transplant, and then we'll drill down on some of your disease management engagement. So transplants, looks like we had about 3 in the period that we're looking at. All of those were bone marrow transplant and all at COEs. Um, but out of those 3, we had just 1 that was completed. Currently, there's 2 awaiting transplant at both BMTs, as I mentioned. And then so far for the 1 completed transplant, there's the savings noted for that 1 transplant. And disease management, again, we talked about programs, the decision support programs, case management. Here's just a drill down of your members participating in disease management programs, diabetes, heart failure, coronary artery disease, things of that nature. We had 323 members qualified. Again, 192 unable to be reached. 14 just said we're not interested and opted out. We had 85 members that we touched and 50 members that we engaged. And you can see the engaged net paid and the amount of mailings that we sent out overall, and with a majority of them for diabetes.
Hey, Mark, this might be a dumb question, but where do those transplant savings come from? Hello?
Yeah, no, I'm trying to think of a good answer for you, and hopefully that's a little bit out of my range, but I believe, and Carol, maybe you can help out here. It's really based on engagement and going to a COE. I think it probably has to do with improved outcomes as related to receiving treatment at a COE. Does that make sense, Carol?
Center of excellence.
Yeah, exactly.
Yes, absolutely.
And that's something we always strive to do, is centers of excellence obviously have much greater, more successful outcomes because they're set up to do, more in-depth treatments. They've done it before, they're practiced. So that's part of it, definitely.
Mark, do we know if this individual, were they on the Nexus plan or the Choice Plus plan?
I don't have that information.
Matt, Tanya?
It might be interesting is for us to look at that. I'd also kind of like to look at engagement statistics by plan, because in theory, a lot of the savings that we're seeing under the Nexus plan is due to better overall engagement, better health decisions, and so forth. And we kind of saw that in that slide where we compared the statistics side by side. But let us have as a takeaway to drill into the clinical engagement, these numbers on a plan by plan basis, because I think that would be interesting.
Yes, absolutely. So any other questions, folks? .
This is Shelley. I have a question. Is there possible on engagement on trying to reach members through their Rally portal? Either like a message or an email to Rally? The reason I say this is we recently received a complaint. Did receive a UHC call that we think it's a UHC call. The member's concerned because the caller didn't really identify UHC and was asking a lot of questions, especially about a son. And when we tried to call back that number ourselves, it didn't go back to UHC. It seemed to be a lot of like a solicitor. So I just wonder if reaching out through Rally would be another way to improve engagement.
Yeah, I think, anytime that we have an opportunity to talk with a member, whatever the source of that is, I think is an opportunity to educate them about the programs that are available, and how we can help. I'm not sure, and I'd have to, again, talk to my UHC partners here, if a person who calls Rally can actually get a person enrolled in a clinical program. I suspect not. However, I can say the Rally person would have information available to provide to the member to say, hey, here's a number. It might be the A4Me number is always a great portal for a member to start with, because their call can be triaged as if it's a claim or if it's more of a clinical issue, then we can disseminate that call to the right place and get somebody involved in a clinical program. As far as the other question, remember, no, go ahead.
It's not right. The concern was getting the member received a phone call and it did not identify UHC, which you explained that could be by the carrier. But the way the member described how the call went, it put the member felt very uncomfortable, did not, especially in today's status that, sometimes you get these solicitation calls and did you know that you could put money here or buy this here? And the way that member described, really, this member wanted us to bring this situation to UHC to say that there should be a better way. We did explain to the member that there's typically a phone call and there is typically a mailer that goes out as well. But it was and I don't know if it's just with this member, other members, they're very hesitant because they don't trust who's on the other line of the phone. They don't know, you know what I'm saying? So it just happened in this situation that the phone number didn't identify UHC. The way that member described the conversation was not one that you're describing here and what happens. And then when we, again, tried to call back that number, it didn't even go into UHC. So it alarmed the member. So my message would be is not that I expect someone from Rally who just maintains the portal, but using Rally as a way to reach members. Hey, maybe it's an email because we're pushing everyone to go to Rally and watch their wellness actions. But if they could know that they're getting secure messages, or even if it's not through Rally, it's when you log into your MyUHC portal, you have patient portals, something like that, just so the member knows it's secure. They're actually talking to UHC and what the purpose is and how to get that member engaged. That was all I was really going with that.
So Marty, this is Cynthia Long. I want to just caution changing our entire protocol over one person. That phone call you're talking about almost sounds like it was a phishing phone call, and it might not even have been UHC. I think we need to drill down a little bit more on that particular call and that person before we, throw the baby out with the bathwater.
Commissioner Long, this is Matt, and that is, I apologize. So whenever there is a call from United Healthcare, we will always proactively, we will share that we're with United Healthcare. It will always reference United Healthcare, and we will never make a marketing outreach for any of our products. we may refer members to either a clinical or wellness program, but they'll never receive any type of communication from us about a marketing opportunity or a buy-up type opportunity. So it's great that your employee was hesitant and that questioned that call, because that does sound like it wasn't from one of our programs. And Shelley, that's a great point about the engagement from the Rally app. I don't know that we do that. We use all of our we try to use all of our touch points as ways to route members to our clinical programs. Not sure about the Rally specifically, but let us have that as a takeaway too, to see if there's anything on the horizon about leveraging it.
And Mark, this is Carol. Did you mention our migration to a more digital platform using texting as we move forward?
I had not mentioned that. No, that's a great point. Do you want to talk a little bit about that?
I just know that one of the mechanisms that we are beginning to implement is a texting outreach to individuals. I'm hoping that that'll be well received, and I'm not sure exactly when it's going to start for Williamson County, but we can see if we can find it out.
Absolutely, and I think that would be a great way to help your members to increase their trust level about who we are and what's behind it. Shelley, as you mentioned, I totally understand. You know, when anybody gets a call these days, it's your first kind of move is to suspicion. And I agree with Matt. When our staff outreaches to members, it really is part of our policies and procedure to clearly state who we are and before we move forward, and we're very respectful of HIPAA rules and regulations. So, we do our best to build trust with your members and help them understand that it's a real call. So I hope that helps.
Okay, thanks, Mark. This is Amy again. I'm going to take over, and I do just want to extend both Tanya and Norlisha had tried to comment in the past few moments to piggyback on some of Mark's comments, and apparently we weren't hearing either one of them, but Norlisha did want to just basically, she sent me some comments, but they basically reiterate everything that Matt was saying as far as, we're not going to solicit anything, and all of our calls are identified as United Healthcare. So anyway, I apologize for that. But I'm going to, starting here on slide 15, going to shift gears a little bit. Looking here at your site of care, where your members are seeking care, if they're getting care at the appropriate place, at the most cost-efficient place. So starting at the left, just as far as network utilization, 97% of your claims were in network. That's right in line with the norm, and a slight improvement over where you were last year. Quality, here we're looking at your premium provider utilization, dead even with where you were last year, 45% premium provider utilization, and you're doing very well compared to that norm. You're 8 points above the norm there. And on the bottom, those charts are just kind of some key metrics that we look at in each one of these categories to, to show you why we focus on each one of these categories, because of the quality and the cost outcomes. Then going to the third column there, cost efficiency. Here we're really focused on your outpatient surgeries and having those done at an ambulatory surgery center versus an outpatient hospital center. And you can see there as an example, just the cost differential of having those surgeries done at an ambulatory center. So you've got 87% that were done at the optimal site as compared to 80% last year, which last year you were even with the norm. So you're doing well there as well. And then finally, looking at your on-demand care, and we'll look at this in more detail on the next slide, but basically, when people have urgent or emergent needs, whether or not they're using the emergency room appropriately compared to virtual visits or urgent care. And you had 73% optimal ER utilization there, which again is almost even with where you were last year and with the norm. And if we go to the next slide, we've got a little bit more information just on the on-demand portion. So your ER visits, you had 171 visits per 1,000, and you can see how that compares to both the prior period and the norm. This norm is a little bit high because keep in mind your norm is Texas municipalities. We've limited it to just state of Texas. And Texas does run a bit higher than the rest of the country just because of our prevalence of freestanding emergency rooms. So it's a relatively high norm compared to our national averages, but you're doing 13% better than that norm at 171 visits per 1,000. Urgent care utilization was at 296 visits, which is up about 3% and 12% higher than the norm, which we want to see that shift from ER to urgent care when appropriate. And then finally, your virtual visit utilization went up, almost doubled from last year, actually more than doubled from last year, and is 74% higher than norm. So that's great. I mean, that's definitely one of those word of mouth benefits that as employees start to use it and tell their coworkers about it, more people will start to use it. We're definitely going to see upticks in virtual visit utilization when we review this data next year because, of course, people are starting to use that more often given the current COVID situation. At the bottom, just kind of showing some, some of the cost impact. So the first number, that 168,000, is saying if 50% of the ER visits that we could have redirected, meaning they were conditions that could have been seen in an urgent care situation, things like upper respiratory infections and UTIs, if 50% of those had gone to an urgent care instead of being treated in the emergency room, your savings would have been about $168,000. And then the next number is basically saying the same thing. If we had shifted 50% of the virtual visit users of the urgent care users to a virtual visit setting, your savings would have been about an additional 17,000.
Question on that. Let's go back to that slide. Do you see an effectiveness or the ability to control this through a separate freestanding ER copay, or are there employers moving that direction? We tell employees, here's a separate, these freestanding emergency rooms are more expensive, considerably more.
Sure.
I'm going to having a separate copay that's specific to. I know there's some communication issues to get through, but
I'm going to ask either Matt or Tanya to weigh in on that. They can kind of discuss more if that's. I'm not even sure if that's possible from a benefits modeling perspective. I'm going to ask one of them to weigh in.
On you, Matt.
I apologize. So yes, we haven't seen very many plans going down the road of a separate urgent or separate freestanding versus facility ER benefit. We can, I believe, we can administer that, but what we have seen a lot of customers move to is additional cost sharing, and especially the deductible coinsurance for ER visits, so that the net effect is that members see a higher out-of-pocket cost when they visit those more expensive freestanding facilities.
Okay. Thank you.
Okay. So kind of transitioning here to our health activation index. This is really a score of your members' decision making when they make the optimal decision based on their healthcare. This is my first year working with you all, so you might have seen this in the past. We used to call it Consumer Activation Index, and it was a chart that sort of looked like a spider web. And we've simplified it a little bit here. All the same measures and concepts, but we've just kind of cleaned up how we are displaying this, and hopefully this is a little bit easier for you to read. In essence, if you look there in the middle, that 21,985, that's the number of healthcare decisions that we've actually measured for you in 2019. And of all of those decisions, that score at the top, that 75.8% is saying that 75.8% of the time your members were making the optimal decision, compared to the norm of 67%. So as you look over some of the things that go into this, so site of care, so everything that we just talked about on the previous two slides, your ER, if they're choosing a urgent care versus an ER, if they're staying in network, Are they using a premium provider? So you're about 58% optimal score there. And you can see next to that just the actual number of decisions in each one of these categories that we mentioned. The following, the next several items, prevention and well-being. So those are looking at like targeted cancer screenings, your wellness visits. And you've got great score on your well-being, 94%. So that's great. And just as you read that bar, that gray range is a range between our norm and what we call our trailblazers, which are our groups that are really at the highest end of each one of these metrics. And then the blue bar is where you are. You don't have a prior score because we have to have 2 full years of data, and this is only your second year on the plan this past year. So normally you would also be able to see your improvement over year. Diabetes, asthma, coronary artery disease, and then the final one, other conditions at the very bottom. Those are all looking at things like your disease management, engagement, compliance with evidence-based medicine guidelines for each one of those conditions. And then resources and engagement, that's your engagement with our clinical programs, and then resources, whether or not they're using the consumer tools, things like myuhc.com and the healthcare cost estimator. So overall, doing a great job. Your members have this is a great activation score, well above the norm. Next year, as we look at 2 years of this data, I would imagine that most will have some even better numbers. And with that, I think the next few slides are Carol's. Carol, are you on?
I am.
Okay, great.
Yes, I'm so glad I can talk now. Yeah, I wanted to reiterate Amy's good news. That's one of the highest activation scores I've seen for any client. So members are really making good decisions. Yeah. Okay, now this is looking at adult wellness. So you can see that we saw that excellent score of 94% well-being activation, meaning adults that went in for their annual wellness exam. You're well above the norm on that. And in the bottom right quadrant, what we're looking at is the wellness visit impact on cancer screenings. So the dark blue bar indicates members who had a wellness visit and had their cancer screenings. The turquoise is screening rates for folks who did not have a wellness visit. So you can see mammography, cervical cancer, and colon cancer screening activation is much higher for folks that have adult wellness visits. The overall screening rates for the guidelines are to the left of that. So you can see mammography screenings are indicated for women at age 50 every 2 years. Cervical cancer screening is for all adult women based on their age, a range between 3 to 5 years. And colon cancer screenings are recommended at age 50 every 10 years. So very, very good rates. Next slide. Okay, this is adult disease progression. So this exhibit basically buckets continuously enrolled adults into categories based on their metabolic risk. And when we talk about metabolic risk, what we're talking about is a combination of risk factors leading up to prediabetes and diabetes, including hypertension, hyperlipidemia, and obesity. And you can see of the continuously enrolled adults, by far, we have most people in the non-metabolic category. That's terrific. Now, that doesn't mean that they don't have any medical issues, but they certainly don't have metabolic risk, diabetes, or heart disease. 400 are in the early risk category, meaning they had one of those 3 risk factors that I mentioned. 227 had 2 of those risk factors, hypertension, hyperlipidemia, or obesity. We've had 37 folks with the diagnosis of uncomplicated diabetes, 139 with diabetes with complications, and then 40 that have already developed some form of heart disease, including coronary artery disease or heart failure. Now, what we did see is that 18% of adults did progress to a higher state of risk in this period. 1% improved their health risk and 81% maintained, but we did see 18% progress with a medical cost progression of over $995,000. What we expect to progress in next year is at 9%. That's just based on age, gender, geographic risk. And with that 9%, our estimated additional medical cost would be just over $1 million. So the point here is if we can do anything to slow down that progression, helping people just lose 3 to 5% of their body weight will slow that progression significantly. Next slide. Okay, so these are our clinical cost drivers. These are led by, and they're largely driven by your catastrophic. So this is rankings based on medical paid PMPM. In first place, we have the neoplasm category. That was 17% of your medical spend, impacting 10% of members. In the catastrophic list, you had a variety of cancers. I wasn't able to hear Amy's explanation of that slide because I was trying to get back on audio at the time. But among your cancers, we saw lymphoma, leukemia, brain cancer, lung cancer, bone cancer, colon cancer, every kind of cancer imaginable. In the other condition category is driven by screenings for suspected conditions. So basically, Dr. Arnold feel-good visits and also medical exams. So that was 12% of your medical paid, impacting, of course, a large percentage of members who were seeking care. Injury and poisoning category is basically medical and surgical complications is what that category is driven by. That was 12% of your medical paid, impacting 16% of members. The musculoskeletal category, which is back pain, joint pain, connective tissue, and then surgeries associated with those conditions. That was 11% of your medical paid, impacting 24% of members. And then finally, the circulatory system was 8% of the medical paid, impacting 16% of members. And that is driven by, heart disease, hypertension, hyperlipidemia, chest pain, etc. Next slide. Looking at adult diabetes, we saw that 14% of adults on the plan had a diabetes diagnosis. That's up slightly over last year and also a little bit above the norm. 23% of total medical was for those adults with diabetes, not necessarily just their diabetic care, but for all of their care. 47% of those members with diabetes had one or more comorbid condition, including hypertension, which impacted 28%, hyperlipidemia, coronary artery disease, 2.5% had renal failure, and a little less than 1% with congestive heart failure. And then based on evidence-based medicine adherence, we see that diabetes are doing quite well with their physician visits. 97% saw their doctor once every 6 months. And for diabetics, what's recommended is that they see their doctor every 6 months and that they have a hemoglobin A1C test at least twice a year. In addition to that, there are other guidelines like checking their cholesterol level, getting their eyes examined, checking kidney function, etc. But we just selected these two metrics, and as you can see, you're doing better than the prior period and above the norm in both. 299 folks that were diabetic were touched by our clinical program, and then just south of 30% enrolled in one of our clinical programs. Next slide. The musculoskeletal category, as I mentioned, is driven by back and joint pain in surgeries. You can see on the upper right side, we had 8 individuals who underwent a laminectomy, and then 6% had a spinal fusion. The fusions are done typically after one or more of the laminectomies are done, and the bony processes in the back are manipulated, and then the spine becomes unstable and requires a fusion. The joint surgeries, we had 4 hip replacements and 3 knee replacements this period. You can see the cost for musculoskeletal claims went up 28% this period. And we had 8 surgeries per 1,000. We also saw quite high utilization of chiropractic care, which is a good indication that people are at least considering alternatives to surgery, at least it, as an alternative or prior to making a determination that surgery is necessary.
Hey, Carol.
Yes.
So on these the joint surgeries, actually, first of all, what period is this covering again?
This is 2019.
Okay, just 2019, doesn't come into 2020 at all.
No, not yet.
Okay, good deal.
Uh-huh.
That's all I have.
Yes, and for this particular group, I think it's really important that they use our high quality premium providers. And you can see 41% did choose a premium orthopedic surgeon, 64% chose premium internal medicine doctors, and 45% with family medicine. So your use of our premium doctors is very, very high. It's excellent. 7 members engaged in a program that we call decision support. And in this instance, decision support is looking, the nurses are looking through claims and they see indications that perhaps a person is thinking about back or joint surgery. Maybe you're seeing chiropractic care, back injections, lots of visits, to the orthopedic surgeon. Then our nurses will reach out and talk to people about alternative care. If they are choosing to have surgery, we try to steer them to our centers of excellence, and again, steer them to premium providers if they aren't working with one already. Next slide.
Can you go back for a second? Go back to the extent of the lower back surgeries and some of the back surgeries in general. I mean, do y'all get a sense of how just all the clinical data, all the claim data that you have, how many of those are unnecessary? Because we're just hearing from our clinical team and from other experts that there's as many as half or 2/3 of those could be, there's other alternative ways to treat them through physical therapy before they get to that surgery. I mean, can you all just shed some light on that for us?
Yeah, I couldn't quantify how many of these were not necessary. I don't think we have the data available to us to do that, but I will say that we always try to encourage alternative, less invasive therapy first, and that's what this decision support team is all about. That's truly what they're focused
I believe we can quantify the number of members who went straight to the surgery or to a surgeon and did not have that the lower acuity care first. So let us have that as a takeaway and see if we can dig into that.
Yeah, I think if we find the individuals who are going in for treatment and then there's outreach or some just to show them, and some of these people are clearly in pain, and we've all either had back pains or know someone that has, but we want to see if there's other ways to treat them first before they go straight to a specialist, because we know what the answer is going to be if that happens. But physical therapy is a legitimate option in some of those lower back pain instances. I think it's worth exploring or ways to engage those people, continue to engage them.
Okay, shall we move to the next slide? All right, so this is about active cancer treatment. We saw 17 claimants with a new cancer in 2019 undergoing chemotherapy, radiation, or surgery. That's fewer than the prior period. We had 22 with new cancer. 2 of those individuals had leukemias, and I'm sure those were, the folks that we were looking at with the bone marrow transplant. We had 1 unspecified cancer. I looked at that one in more detail, and it looks to me like it was probably a lymphoma. There was 1 brain cancer, and you can see the cost for each of those conditions much higher than the norm. Let's see, in terms of clinical prevention, activation, or cancer screening rates, we'd be remiss to talk about cancer and not look at those rates. And as you saw earlier, your rates are quite high, 79% for mammography, 100% for cervical cancer, and then 34% for colon cancer screening. And remember, this is just a 2-year look back that we're We're measuring when the evidence-based guidelines, for colon cancer screening is every 10 years, so 34% fine. In terms of cancer guidance, that is a program basically that where we make sure that once an individual is going on chemotherapy, that they are on the most appropriate, cost-effective medication that's based on their condition. Okay, and those they're currently receiving IV or oral chemotherapy, radiation, or surgery. It's just basically a program to make sure that people are receiving the best care possible. Next slide. And I think this will be my last one. This is looking at behavioral health solutions. So 14% of members did have a behavioral health diagnosis. The three most prevalent were depression, substance abuse, and bipolar and related disorders. I also think it's interesting and not at all unusual that dependence accounted for 32% of behavioral health claimants and 70% of behavioral health paid. 1 in 5 American adults is affected every year by mental health or substance abuse. So these numbers are not at all unusual. The good news is we did see high behavioral health in-network use at 84%, 98% mental health in-network use, which is terrific. And then you can see the dependent percentage cost for each of the conditions below was quite high. Okay, I think that's it for my slides, and now our conclusion. I'm not.
This is Amy. I think Tanya's having trouble. She was going to wrap this up. I think Matt's going to do this instead.
Yes,
Matt, are you there?
yeah, I apologize. I was on mute again. So we went through a lot of information, but we wanted to provide a summary slide for you for the key takeaways. Overall, in my mind, the takeaways are that at least from a claims out the door standpoint, that the financials look good compared to what we would have expected based upon our normative data. Engagement is positive, though we have the opportunity to improve. So we touched the high-cost claimants very well with our clinical programs, but we saw in the data that we still have an opportunity for those folks that are kind of in the middle of the continuum, that are between the well and the chronic conditions. We need to dig a little bit deeper and see if there are ways that we can improve our touch points on those members. Overall, decision making was fantastic, and I think the Williamson County team deserves a lot of kudos for getting the information out to your members so that they're doing those preventive care visits and the other things that they need to improve their health. We still have some opportunities on population health to look at how we're engaging with members in those key drivers like neoplasms and musculoskeletal, to see if there are ways that we can improve their access to care. Then overall, on our site of care visits, we're doing pretty well, but we have an opportunity on ER to direct more of those members to maybe a lower point of care, either primary care visits, urgent care, or virtual visits. And we welcome the opportunity to talk about that further when we get into possible plan changes for 2021. Before we transition over to the pharmacy discussion, are there any questions about what we've presented so far, or anything else that you'd like us to dig a little bit deeper upon?
I'm good.
Okay, great. Jamar, are you ready to begin the pharmacy discussion? Jamar, are you out there? I see you online. Are you on mute?
I was having the same problems that they were earlier, and I basically just joined the on the computer call. So Jamar, you might want to try that. Hang up the phone and just audio. One of the options is to connect to your computer.
Okay, he dropped. Hopefully he'll be right back. You guys just want to
Need a break?
Yeah, you want to do
Matt, can you hear me?
I can hear you now, Tanya. Do you guys, Jake, do you want to do a 5-minute break or a 3-minute break real quick?
Anybody need a break? Let's do a 3-minute break.
Thanks,
Thank you,
Jay.
everybody. Hello, Jamar, is that you? It's testing.
Matt, I see him on and I see his headphones, but I don't see, oh, and then headphones just went away too.
Yep.
Jack is on. I wonder, Jack, are you there?
I am here. Can you hear me?
We can hear Jack. Okay, well, that's good to know.
Can you all hear me?
We can.
Hi, Jamar.
Oh my goodness. I tried to call in through the computer multiple times. So what I ultimately did was just pulled up the dial-in number and called in on my cell phone. My apologies for that all. All right.
You sound great. We're taking a little bit of a break. We'll probably start in a couple minutes.
Oh, okay. Okay, I thought I was slowing the show down.
Nope, you're good. Quick break.
You gave us a good opportunity to take a break.
All right.
Hey, is everybody back? If you're not back, speak up.
I'm back, Dad.
Can they speak up if they're not back?
That was that was the whole thing. I'm glad you got that, David. I was falling on deaf ears.
I get your humor, Jay.
Hey, can everyone hear me? It's Tanya.
We can.
Yes.
Yes, Tanya, we can hear you. We heard Jamar a moment ago.
Okay, let's go ahead and get started.
Jamar, are you out there still?
I'm here.
All right.
It's all yours. Go ahead.
All right. Well, good morning, everyone. Thanks for giving us the opportunity to speak with you today. So we'll jump right into the pharmacy executive summary and continue the good news from the medical presentation. We have a negative 4.2% trend with the pharmacy plan paid per member per month. You know, I think a lot of that is driven by, you know, the collaboration of the benefits team, the benefits committee, and Holmes Murphy of adopting some recommended solutions over the past few years. And I think some of those are really coming into fruition in the 2019 plan data. So the big area of driving that trend down was non-specialty. You see it decreased by nearly 17%. Tied a lot to the exclusions you opted into and clinical programming. Where we see the increase, which is, you know, not unique to Williamson County, but all across our client base, is in specialty pharmacy. About an 18% increase there. And, you know, we'll get into the details, but just to give you oncology inflammatory conditions were the key drivers there. Inflammatory conditions, I think we've spoke, you know, in several meetings before that that category of medications will continue and across the board drives cost. Oncology is one that's kind of popped up in there over the past few years. Just because there's a lot of development in the new drug pipeline to address cancer. So we'll get into the details of that. And just hitting on the bottom metrics real quick, your utilizers stayed pretty flat. Specialty utilizers, 2.2%. That's within the range of what we generally see, between 1% and 2%. So you're on the higher end. That about 86% generic dispense rate. That's a good number there. We're starting to see some clients move towards that 88%, but still you're solid and well within the norm range for the generic dispensing rate. Slight downtick in adherence. Okay, we can the slight downtick in adherence, but those numbers still look great as well. Anything above 80%, we consider adherence using the portion of days covered methodology. Right, and then comorbid members, that's where we have a slight increase there. So, and a little bit above the norm as well. So members that have 2 more conditions that are taking, I believe, 2 or more drugs for those conditions as well. All right, so we can take a look at the historical performance on the next slide. It shows 4 periods, but of course, we don't have that data on there. We don't have that data for you all, so we have 2 periods, and over 2 periods, we have a negative 1% trend. You can see the different metrics below and how that compares to the norm over those over that 4 period time. The norm has a 4.3% trend. But yeah, I think, you know, once we have more years of data, this will give us a more full look and how things are moving compared to the norm.
And Jamar, quick question for you. As you go through this, is this gross spend or is this net of rebates?
So it is gross spend. I do have a slide that does factor in rebates. So, and I believe that may be It's coming up, either the next one or the
Perfect. I
next.
just want to clarify. It's because the rebate dollars are pretty significant that the county gets back, and ultimately that, you know, belongs to the plan, and we'll use that when we look at the budgeting piece, but just want to clarify. Thank you.
Sure thing. All right. So, plan performance summary. So we have a look at the components of what's driving trend for the 2019 plan year. Utilization up slightly, pricing and inflation up 1.4%. This is an area we usually see, well, you know, in years past, we would see brand medications inflating at double-digit percentages. So, you know, over the past couple of years, it's really been trending downward in terms of inflation on drugs. Probably the biggest mover of the component, the trend components is drug mix. So when we see that decrease in drug mix as we have here, that -8%, just means members are taking more generics or more less expensive medications. Directly resulted to some of the plan changes that you guys decided to make. And then you have the employee cost share. I think you all have a really solid benefit design in place that, you know, helps keep costs stable with the increased cost of drugs year over year. And then the bottom chart really just shows a comparison to the norm. So, you know, we have the plan paid per member per month of $133.57. It's still above the norm and our book of business, but I think with the changes that have gone in place over the past couple of years, you will continue to trend closer to that norm range. And, you know, we'll continue to bring opportunities to the table to drive savings as long as, you know, as long as they make sense for your population. Any questions here?
Jamar, this is Cynthia Long. On the specialty in particular, I know we're trying to drive to obviously generics, but those specialties don't really have generics. I mean, what, you know, and my only knowledge is, you know, I see the advertisement and I go to GoodRx to see how much that costs, and I'm astounded. But, you know, there's a migraine medication that is $800 a pill. I mean, what are our opportunities to control in that specialty area?
Yeah, that's a great question, and I think that's the biggest or the toughest question that we have to answer is how are we going to contain, or how are we containing those costs? And you know, a lot of it has to do with the utilization management programs that are currently in place to ensure that, you know, that the person has the right genetic makeup for the medication to work. You know, that's one thing to cut costs related to waste of medication. You know, another thing that we have in place is, you know, I mentioned the pricing inflation, but for about, I want to say 90% or so of all of the brands that we cover, we have price protection in place that if they inflate to a certain range, we essentially get kickbacks from the manufacturer that gets passed on to clients. And a big one that we're kind of banking on and have been banking on for years, which has kind of been delayed by patent litigation, is biosimilars. And I think for the 2020 plan year, you'll see, and sorry, Jack, kind of stealing some of your thunder here, but for the 2020 plan year, we expect to see some savings in, is it oncology, neutropenia, and multiple sclerosis as we're driving towards the utilization of biosimilars in that category. So those are a few things that we're doing. I know, you know, once we get into the specialty section, Jack will provide some more details around pipeline and how we're, protecting dollars. But those are a couple of things I could think of off the top of my head.
Thanks.
All right, we can go on to number 5. And David, this slide shows the value of rebates. So, we spoke about the $133.57 plan pay per member per month, but when we factor in rebates, we actually have a $94.52 plan pay per member per month and a negative 13% trend. Below you can see the top 10 conditions, and a lot of these conditions are actually your top conditions by spend as well. So diabetes, you can see, I believe it may be your number 1 or number 2 disease state. The rebate value, or I guess you can say, pretty much you're getting a 49% discount when rebates are factored in on diabetes products. So, we had a good year without rebates, but when we factor in rebates, makes the year even better by taking those costs down.
Yeah, it's pretty much spot on with what we have as well. The numbers significant, it's growing, it's driven by specialty a lot. Now you've got greater generic dispensing rate that's been improving, that helps offset some of those specialty costs, which people, like you said, Commissioner Long, there's not a lot of alternatives for. People need those drugs. We don't want to put barriers in front of them, but the good on the backside, at least the rebate number is significant, and it's growing, and that comes back to the plan.
And David, I do want to hit on that. It's growing, and I know some of the changes that are made for 2020 going forward, specifically on the diabetes, preferring those, or having our preferred alternatives preferred on that's only going to help raise that as well. So change, like Jamar was saying, changes that you've made in the past, we're starting to see those changes come through as far as costs going down. So the suggestions that were made last year, the year before, and so on. So they're starting to roll through.
Yeah, I agree with that. There's been a little bit of an uptick the first quarter, which we'll look at on the pharmacy when we go through the budgeting piece. But overall, I would agree with you, Jack and Jamar. Correct.
And tied into this, the rebate topic is I don't think it's something that is currently on, but there's an opportunity, for members on the point of sale discount program, which essentially it passes on a portion of the rebate value to members at the point of sale, at the point of fill. That may be on the HSA in the deductible stage, so they get a discount off of their drug cost with that point of sale discount program. So that's something we could potentially look at as well, putting in to help reduce the obstacle of high costing drugs for your members.
And I do apologize. I missed who was speaking, asking about that. They looked up and saw how much that high cost med is as well. And I'm sure it was an inflammatory drug. Those seem to have the most commercials. But again, this is one of those areas that we negotiate on behalf of the county and try to get that rebate. And we prefer those agents and to drive those cost savings there as well. So this is another avenue, as Jamar was talking about, utilization management and so on. We have this as we're working on this as well to help get cost savings there too. Sorry to interrupt you, Jamar.
Oh, no, you're fine. Okay, so we can take a look at the top 5 disease states driving plan paid. Next slide. And I'll just kick this off and hand it over to Jack. But you'll see that, all of these are specialty products. And I think did you skip one? Or did I?
Go back to slide 6, yeah.
Okay, thank you. All right. So top 5 disease states. You know, we generally see the 4 of these 5 in the top 5 for almost every client. You know, usually inflammatory 1, diabetes 2, oncology and MS in there as well. So again, I mentioned on that previous slide, the rebate slide, diabetes, you had a 49% rebate value, inflammatory at 39%, multiple sclerosis 15%, and then ADHD 49%. So you can see that the costs are increasing in most of these categories with the exception of diabetes, but those rebate values are kind of offsetting those increased costs as well. So just wanted to add that, and I'll turn it over to Jack to kind of hit on the actual disease states.
Yeah, thank you, Jamar. So kind of taking a deeper dive, again, as Jamar was saying, this is a good chunk if we look at what are you spending your money on. 66% of the total plan paid is on these disease states. And when we talk about diabetes, only think of diabetes drugs. I know previous slides, on the medical side, we can talk about a diabetic, and a diabetic's going to have more than just diabetes meds. They're going to have probably blood pressure medications. They're probably going to have some cholesterol medications. So when we talk about on the pharmacy side, we're only talking about drugs that are designed for diabetes or that A1C treatment. And as you can see on here, that as Jamar was talking about inflammatory, oncology, multiple sclerosis, we see those as well in just about all of my top 5 conditions of all the plans. And those are specialty conditions. And one of the differences between the middle 3 as opposed to the outside 2 is it's really driven by a few individuals, especially that oncology. Only a few members are taking cancer-related drugs that are really driving that spend. And so that's really where the difference is. And someone was talking about the high cost of drugs. Really, it's if you look at those 3 categories, that's when they'll pop up as well. As far as diabetes, multiple sclerosis, and ADHD, those trended down a little bit. Those can be related to the decrease in utilizers, as you can see on the far right-hand side. But we also saw some good drug changes as drug mix, as Jamar talked about in the previous couple slides. Members choosing the appropriate treatment as well to help drive down some of that cost. As far as inflammatory goes, and I apologize for not saying this right, when we talk about inflammatory, it's more than just one condition. Diabetes, is diabetes, ADHD is ADHD, but inflammatory is kind of a group of diseases that, think about it this way, where our immune system is attacking some part of our body. And so these help control that, but it could be attacking different parts of our body. And so when I looked at some of your cases, it's across the board. We have it to where the skin is being attacked, and like psoriasis, it shows up in the form. There are some bowel diseases as well, ulcerative colitis, Crohn's disease. There is also where the joints are attacked in psoriatic arthritis or rheumatoid arthritis. And as we get down to the specific drugs, you'll see that a lot of these drugs are indicated for multiple indications. If there's no more questions, we can jump. If there's no questions, let's jump down and dive into specific drugs, and then we can kind of loop back and see if there's any questions overall. So I'll pause here. Are there any questions on the top 5 conditions? All right, Tanya, let's go ahead and move down to slide 7 then, which would be your top 5 drugs. So if we take a deeper dive, okay, we had our top conditions. What are we spending on? What are the drugs that cost so much? And I apologize that this slide doesn't do a very good job of telling you what they're indicated for. If you look at Jakafi, which is that very first drug, and Revlimid, which is that very last drug, those are your cancer drugs. As far as your high-cost claimants on the pharmacy side, and they showed up on the medical side, these members were taking these drugs. And they are used for multiple different cancers. The Jakafi, there's 2 members taking it. They are using it for 2 different types of cancers. It's a great drug. It works really well, but it's 2 significantly different types of blood cancers. And Revlimid as well, that's going to be used for a multiple myeloma. I apologize. And so, as we look for the cost there, that member just had a full year's worth of fills. Kind of Revlimid, I do believe that drug is slated to go generic within a year, so that is some good cost coming down. Hopefully this member will be cured by that time and maybe they don't need to be on it, but it is something coming down in the pipeline. If we look at those three middle drugs, Humira, Stelara, and Xeljanz, all of these drugs are used for that inflammatory condition, and most of these are used for multiple. Humira has over 77 patents on it. It's approved for like 13 indications, a lot of juvenile or younger under the age of 18 diseases as well. So your ulcerative colitis, Crohn's disease, any type of rheumatoid arthritis. Stelara as well is approved for many of those same conditions. And you'll notice Xeljanz is up there too. Xeljanz was primarily approved for rheumatoid arthritis. It is getting additional indications as it goes along. One of the significant differences between Xeljanz and the other drugs, Humira and Stelara, is it's an oral medication. So, but as Jamar was talking about, when it comes to those rebates, one of the things that we've done in 2020 is we've kind of pushed Xeljanz. We've able to negotiate better pricing on Xeljanz. So as far as those rebate dollars go related to that specific medication, you know, we're advocating for the plan to make sure that we can get the best available pricing on that drug.
So
Let me stop here.
Just one circle back question. The plan cost per prescription that you have listed, that's before rebate, is that correct?
Yes, ma'am.
Thank you.
And you're not gonna, you know, we're not gonna be able to get an exact number, but you can kind of estimate if you were to like the oncology and get a percent. That's just kind of the overall disease state to see where you're saving, but it does kind of give you a relative idea. And on this too, you can also see the number of utilizers per the norm, and some of them do stick out. The cancer ones are going to stick out. They're very rare cancers, multiple myeloma, and then the other type of blood cancers with the Jakafi. So that use is going to seem high, but it's just those specific type of members. And like I said, that's 3 members total that are driving that, and so that's really what's driving that spend. But if you look at something like Humira Pen, which is our #1 drug across the book of business, we're quite a bit lower than the norm on that. So that's very good to see. Xeljanz is a little bit higher as well. I was talking to Jamar about this. It wouldn't surprise me. I think that when the plan migrated back in 2018, that was the year that we saw like a bunch of people are established on that. And so as opposed to making them jump back through hoops to get on this medication, I think they were continued with some grandfatherization type programs. Are there any questions about the top 5 drugs on the pharmacy plan? All right, let's go down to the next slide. And you kind of heard us talk about, you know, one thing that's nice about the plan setup is, you know, there's going to be a drug that's covered under medical and pharmacy benefits. So we can talk about where it's covered and why here on this slide. And so if we break down the specialty drugs, think of your innovative products, your IV chemotherapy is just, and your inflammatory conditions we were talking about here. All those are specialty conditions. But some of those drugs and some of the innovative products are covered on the medical side. And what really breaks this down, and the easiest way to think about it, there are some exceptions, but if you can do it yourself, for example, an oral tablet, it should fall under the pharmacy side. If you need a provider to help you, it falls under the medical side. And this is where we can kind of see where the benefit is, where the drug is that's falling out. And this is that disease state. So very similar to what we saw before, but just kind of breaking it down. Again, this is just specialty disease states. So you saw a couple of them fall off. ADHD is not here. Diabetes isn't here because these are just the specialty disease states. And as we were talking about before on the medical side, there's that oncology spin that shows up. And you can see it shows up on the pharmacy side as well. The medical side will be that light blue, and the pharmacy side will be that dark blue. one of the things that I really like to show on this slide, and we'll come back to this in a couple more slides, is when we decide where we want to cover the drug, how we're doing that utilization management, how we're looking for cost savings. We look at it across both benefits. We're not going to shift costs on the pharmacy side to the medical in order to give you better numbers to show savings. We're not going to shift it from the medical side to the pharmacy side in order to show savings or to show better utilization or anything like that. We want to try to find the lowest cost and the best treatment for your members. And so a lot of these, PDL updates that Jamar, Tanya, we come to you with are on both of these benefits. So Jamar was alluding to this earlier. So we've come to you and we've made suggestions that we've made, and the plan has adopted these. And this has to do with some of my talking points later on. Biosimilars. What are we doing for that oncology spend? I mean, you have a great program in cancer guidance, but what else can we do? What can we do about those specific agents? Well, as these biosimilars come out, these are the generics for these biologic drugs. We're starting to prefer them. So Herceptin and Avastin, there's some oncology drugs. We prefer the biosimilars. Again, think of them as the generic of the biologics. Now, if a member was still on like a branded product like Herceptin, they could continue that. But this is kind of going forward. Again, as I was telling David, some of the changes we made, we're starting to see that savings. So this is good going on. We've made changes to many of these categories, whether it be preferring biosimilars or preferring certain agents. And so if we look at it, what we've done in the last 12 months, we've made adjustments to oncology on the medical side, inflammatory on the medical side, multiple sclerosis on both the pharmacy and the medical side, and inflammatory conditions on the pharmacy side as well, preferring agents, shifting them to lower tiers, maybe making one or two a higher tier, and so on, to help drive that savings. So it's kind of alluding back to what are we doing on this. So before I dive into pipeline and kind of what we are expecting for 2020, let me stop here and see if there's questions over our top specialty conditions.
Hey, Jack.
Yes.
Thank you. Very good information. And maybe this is a follow-up that's coming, but some of the more expensive drugs that are coming to market, like Zolgensma, if I'm pronouncing that correctly, the $1 million drugs. What is UHC's position on that? Just while we have a whole committee here.
Yes, excellent point. You're still in my thunder on my next slide. You must have gotten the slideshow ahead of time.
I did not.
So let's go to the next slide and let's talk about this. And let me follow up with the committee as well. We do have a general UHC treatment. So that's that very first bullet point, breakthrough gene therapies. And the one that we talked about last year was called Zolgensma. It is $2.3 million. That is a hard thing to swallow, but it's an amazing treatment if we think about it, because these babies that had this disease, very rare disease, 80 to 90% would die by the age of 4. And now we have something that's a cure. Well, we think it is. We don't know long term. It hasn't been around long enough to say in 20 years it's still going to work, but it's an amazing treatment. And these gene therapies aren't going away, as I'm sure you know, David. As we look into this, the one that we're expecting this year is about hemophilia. It's hemophilia type A, so it's a subset, and it's the majority of hemophilia. But what it's going to do is hemophiliacs don't make a clotting factor. And this is a gene therapy, so they will make that clotting factor, basically so they are almost not hemophiliac. Valrox is the name of the drug. If you've heard of that, I'll spare you with the extremely long name. But this is one of those drugs, again, gene therapy. I see lots of dollar signs as well, as I'm sure you do, David. $2 to $3 million is what we're thinking this through. And luckily right now we didn't see anybody on the Williamson County plan that has this. But there are some overall thoughts we have about coverage on this and how to pay for this, how to protect the plan. And David, it's like a 7-page document. I think it might be good if we just send over that frequently asked questions on it, and we could follow up with like a detailed discussion on it. But our thought process is to make sure we're using it for the right member, and we do want to cover it. And so that's kind of our thought process overall. We're not going to exclude this. That is not really UHC's avenue. But as far as like the specifics about payment and stuff like that, we can dive into that a little bit more on that. Does that help answer your question? I think you're muted, David. I see you talking, but I can't hear you.
Sorry about that. Had it on mute. Yeah, it answers it partly, I think, for the committee and for us, just knowing what other alternatives are available other than just immediately covering them. I know there's grants and other manufacturer assistance programs that could possibly help versus the plan having to pay certainly to help somebody and save their lives. That's something that's taken very seriously. There's also the cost element that needs to be balanced.
One of the things that's very different about this hemophilia treatment as opposed to Zolgensma is with the Zolgensma, it's a baby that if you guys had one on your plan, probably hasn't been born yet or is so young that we don't have the claims to do any prediction. With the hemophilia, we're going to know if we have a hemophilia on the plan. They're going to have some spend. And the idea, I've had plans where the annual spend on a hemophilia A is $800,000 a year. So again, if stop loss does consider in this, but it could be, well, I'm exchanging that $800,000 for $2 to $3 million treatment. That's supposedly a cure. Maybe it's worth it in the long term. And so that's where we can have that discussion. But with hemophilia, it is very different that there is a treatment out there. There is something that we have. They should be stable. They're not, like I said, the Zolgensma, those babies basically, there wasn't a lot of treatment options for them besides palliative care. There were other expensive medication. But again, with hemophilia, there are tried and true therapies and so on. But let me get that frequently asked questions out to Tanya, and we can have that as one of the follow-ups, David.
Thanks, Jack.
Just to kind of roll through this slide really quickly, we have other new treatments we're looking at for non-fatty liver disease, non-alcoholic fatty liver disease. This is the #1 cause for liver transplants. We're looking at a drug that can prevent liver transplants. It is amazing to prevent the number of them. And so this is a great new thing that we have coming out. We're expecting it to be approved at the end of the year. Oncology treatments, we talked about, keeps going up. We're starting to see these members stay on these oncology treatments longer. We used to think, okay, you're going to get your 2 to 3 cycles of your chemotherapy and you're done. But a lot of times we're starting to see these members stay longer and longer on these chemotherapies to help them reach that remission, but that does come with a cost as well. And the other thing you kind of heard me talking about, we have a lot of biosimilars in the pipeline. We have a lot more approved by the FDA and a lot more in the pipeline. Some of those are your drugs. Humira is one. It has biosimilars. They just haven't launched yet. And we're expecting those to launch, I believe, in 2023, and we should see a big shift there. But bottom line is, you kind of heard me talking about, the plan has made great decisions already to set us up for success when we do have those decisions in 2023. How do we prefer it? What do we do? How was the cost implication? So that is something to come along. We are seeing a lot of advancement there. We're going to keep bringing you items here. So it's just kind of a preview of what we're seeing. And if we go to the next slide, what are we doing to help curb this cost? This is kind of all of our levers to pull on both the pharmacy and medical benefits. So you can kind of see some of the names might differ a little bit, but it's a very similar program: prior authorization, designated network, and so on. So let me stop here and see if there's any questions on the pipeline and so on that we have on some of the other levers as well.
Not for me, but I do want to say this is one of the best and most in-depth dives we've done on specialty, so thanks.
My pleasure, yes.
All right, well, to close out the pharmacy discussion, we can take a look at the next slide, which shows the clinical programs and the value of those solutions that are implemented. So you can see that, with the prior authorization, which includes notification and medical necessity, the quantity limits, step therapy, are saving the plan $700,000 annually. And that doesn't include the Advantage PDL, which went into place 1/1 of this year, which I believe was roughly 250,000 or so plus. So, the decisions you guys made over time are really paying off. And as we have opportunities to help cut costs for you, we will certainly bring those to the table. And that's all I have.
So David, I think that concludes what we had for our plan performance review.
Perfect. Are there any questions? Commissioner Long, you had some good questions. Anyone else on the committee?
I echo Commissioner Long's sentiments that was a very good and thorough presentation on both sides.
Jay, Rebecca, do we want to, before we jump into the budgeting piece, do we want to take a break so people can grab something to eat for a little bit, or what do you recommend?
We were thinking about noon, but if this is a good natural.
Good morning, everyone. This is Michael Sheehan with County. Judge Perdell, are you on the call, sir?
Yes, sir, I am.
I was gonna say we can. I was thinking we do lunch a little bit later. Maybe we could go ahead and get started on some of the budget and then kind of break back off.
Whenever you're ready, sir.
Good morning. I want to say.
You can go ahead and jump into that.
To the school districts and to the
Judge Gravel, you're not muted.
So helpful during COVID-19, and there's a few updates that I would like.
Yeah.
Can you as host mute him? Okay, thank you. Yeah, we were thinking about noon, but if this is a better time to go ahead, we're good with that.
We can roll with it and go through the budgeting piece, and want UHC to stay on with us since they were part of the initial discussions when we met at the smaller committee. We want to transition over.
David,
go ahead and get into the budget piece, and then as
8% of the folks
as we
are
we can absorb some of that.
8% of folks are testing positive. The recovery rate, we have 217
Shelley,
that have recovered.
You mute Judge Gravel again.
There we go.
Thank you.
I was just going to say, this is Tanya. So Matt, Lori, and I will stay on. Jack and Jamar, any of the other clinical people that may be still out there, feel free to drop off. And we really appreciate your time sharing with the county.
Yeah, thank you.
To the pharmacy team, to the clinical team, we appreciate you. We're going to have the core strategic account team with UHC stay with us.
All right. Take care, everyone.
Thank you all.
Thank
Have a
you
great
so
day.
much.
Thank you. Okay, Caitlin, is Sean on with us? Great. So Jay, you've got myself and Caitlin, Morgan, our public sector vice president lead, is on with us. And for those that haven't been introduced yet, we also have Sean McGee. He is with our financial team. Has a degree in actuarial science. He's a credentialed actuary and has a lot of experience walking through this process and familiarity with our budgeting process and model. We have met previously with the HR staff and Jay and Mel to kind of walk through some options to consider for the next plan year, and looking at a variety of assumptions, which we're going to walk through, obviously using your data, the data that is through March. We've got some assumptions about the COVID impact. We heard Judge Gravel talk about COVID, so we're going to go through that. We actually have some data related to your members on that, which is still very new, but we'll talk through that. We'll talk through plan changes, really to start with the current state, and then what are potential plan changes to mitigate the cost impact and the cost increase. And then we'll look at some different plan options to consider as well. So with that, Kayla, you want to go back to the very beginning, or is this being, it's page 6. All right. So maybe before we even get started, we talked about Williamson County, the state of the union is what we're calling it. Really just now that we have Commissioner Long and Judge Gravel on and the whole committee, from a strategic standpoint, is there anything that we need to be considering as we go through this? There's obviously some people considerations with everything that we're doing, especially now with the pandemic that we're facing. So maybe we'll just stop there and let the other members of the committee weigh in of things that we need to be thinking about. Mr. Long?
David, thanks. I will just kind of give you an overall comment that we've made as a commissioner's court regarding budget overall, and just Williamson County government in Texas is not going to be as drastically impacted by, for example, reduction in sales tax, et cetera, because in Williamson County's case, we don't collect sales tax, but we do expect hits in the out years to revenue, just in terms of commercial appraisals and that impact. So we have not voted on it, but there has been discussion, at least from the dais, that we are looking at a very, very flat budget going forward next year in what we do with budgets in terms of any new programs or personnel. Again, this has not been voted on. This has just been discussion. But seeing what our colleagues, cities and whatnot, what's going on around Texas, at least, I don't think we're out of the realm of that discussion. So the impact to that is going to be, for example, if we don't, and again, nothing's been voted on, but if, it's steady state, for example, and there's no cost of living increase or anything like that, we'll have to really balance what the employer-employee share is going forward and what that looks like. So, I mean, that's just kind of an overall comment of where we are, just general state. The CARES Act funding has, and will make a big difference in terms of covering what our unbudgeted costs were to the for COVID-related expenses, for PPE and overtime and testing and all those various things that we've had to do to prepare for the worst and pray for the best. And so, but as with all local governments and businesses alike, we don't know what we don't know. So we're going to proceed into our next budget very
helpful. Thank you very much.
Sure.
Anyone else? No? Okay. We can go ahead and jump right in here then. So we went to the plan performance. We had our breaks. There will be other breaks too, by the way. Our financial modeling and assumptions, we want to start with that, with the current state, then we can talk about potential changes to consider. Sean, you want to go ahead and take it over from here?
Yes. Current state, what we're looking at here is our per employee per month gross claims over the last 4 years and then year to date through March 2020. So as you can see, the medical is represented by purple color, and these are PEPM numbers or per employee per month numbers for each of the last fiscal years. And then the gold yellow color, that is the pharmacy side. And then down below, you can see the year over year percentage increases based off the fiscal years. So for the fiscal year, for the current fiscal year, through 6 months of data, medical has been trending around 5.5% compared to last year. And then pharmacy is trending upwards around 19.6% year over year compared to last year. And these numbers are all gross claims before any stop loss reimbursements or pharmacy rebates are being applied. Any questions on this slide? Can anyone hear me? Hopefully I just didn't talk all that much to...
Yeah,
we can hear you, just have questions.
We can go ahead and move on to the next one. So you can see the pharmacy spiked up at 20%. So I drove into that a little bit. And as 2019 from UHC was showing that we'd had a great year in specialty costs, everything was down. But as David alluded earlier, first quarter of 2020, the specialty actually increased to roughly almost a 60% average for specialty versus non-specialty paid claims in those months. So as you can see, the fiscal year 18 to 19, the average percentage of specialty paid claims was 37%. However, the first 6 months of this fiscal year, it's trending upwards to be roughly around 51.8%. So we're getting hit a little bit on the specialty side. However, on the back end of that, that means hopefully our pharmacy rebates will also increase as well. David, do you have any other color commentary on this one? I think you're on mute, by the way.
Sorry about that. I apologize. Agree. I think on the back end, we do have the rebates, which are spiking up, and actually the numbers that are projecting out for UHC are higher than when we met a couple of weeks ago to go over this. So we can probably make a slight adjustment to that rebate number, which is a credit back to the plan. But we'll do that when we get there.
Perfect. Moving on to slide 9. This is our medical claims trend look. So what this graph represents is rolling 12 PPM or per employee per month. So the yellow gold line, that is your actual experience. And by each point on that dot, or each dot on that line is a rolling 12 PPM. So we take the last 12 months of claims divided by the last 12 months of headcount. And we lag at 1 month for medical claims just due to processing lag. So we trend that for the 60 months, so roughly 5 years of data. And then we do a best fit curve, or best fit line to that curve, which is represented by the purple line. And then we can have the initial trend for the gross claims for medical side. So over the last 5 years, we've been trending around that 7.6% for medical claims. And these are gross claims before stop loss reimbursements. And then the dotted dash line to the right, that is a look at the last 12 months of actual paid claims for medical. You have actually been trending negative 4.0% for the last 12 months of medical claims. And then we do the same thing on the pharmacy side. Course of history, we've been trending around 6.2%. And then as you can see for the pharmacy, the last couple months, we've had that pretty big spike, which is represented by the specialty claims. However, the last 12 months have only increased around 3.7%. And then for industry average on pharmacy side, typically it's usually in the double digits in the last 12 months. And even across the course of history, it's a little bit higher, around 7.1, 7.5%. So it's phenomenal to have these low percentage numbers at least. Next, we go into our past coverage level. So what I mean by past coverage level, we actually take your actual experience and trend it to today's dollars. So that way we have an apples to apples look how you've been running against your course of history. So typical underwriting, you would focus on the last 12 months and then you would apply trend to that, and then that would be your next year's budget. However, what if we were at an all-time low point? We could potentially be severely under budget, and then on the flip side, we could be severely over budget if we're at an all-time high. So this is our tool to help us develop a starting point to focus on for next year's budget. David, do you want to make any commentary on this one? And you're on mute too, by the way.
Yes, just that, the thing we had, I mentioned before, we may have claims through March. April claims won't be available for probably another couple of days. And I'm not sure if Mel's on or anyone from the budgeting office is on that has a line of sight to that, the daily, monthly, or weekly cash wires from transactions from UHC. Julie, are you on?
No, David, Julie and Mel couldn't be on today, but if we need anything, I'll get in touch with them and get it. They did provide me with the estimate for the year-end fund balance.
Helpful. We were thinking more just of what's happened in April, the cash position for April for the transactions for fund, because Sean's going to go through the COVID impact, because as we all know, as we've been sheltering in place, people have not been going to get their elective surgeries done. Sean and Morgan will talk about that, our process here in a little bit, but we're interested in seeing what that looks like.
Okay, I'll get that.
Thank you.
One last thing on this medical PCL slide. Currently, we're sitting almost at an all-time low at the 767 number. And the different colored lines, so the purple line, that means the 75th PCL, meaning 75% of the time you are below that number, 75 or 25% of the time then you are above that number. And then the blue line represents a flip of a coin. Over the course of history, you've ran, that's your average at 803. So currently in our initial reforecast and budget for 2021, we are using a 40th PCL number. So we're adding in some additional claims dollars to account for our low time right now. And then we do the same thing for the pharmacy side. Currently, we're sitting at the 85th PCL at the 323 PPM number, which is slightly above the 75th PCL. However, and the difference between this one is for pharmacy, the bands between 25th and 50 or 75th are typically tighter than the medical side, so it's a little bit more predictable. However, you can see there's some pretty big swings in this one, but over the course of history, we average around the 311 number.
Yeah, again, just to reconnect on this piece, these are gross claims. We're going to factor in the rebates here in a short while because those have been going up.
Correct. And then these are our 2021 fiscal year assumptions. So we have claims data through March 2020, and it is paid data. We have a full-time employee positions. We are using 1,932 employees or positions to budget against. And then for medical trend, we are using 6.8%, and pharmacy trend, we're using 7.1%. And these are based on Siegel survey industry average trends that we use for all our clients, and we feel that that is a good representation of what the trends will be for this next fiscal year. And then for the PCL numbers, for what we are starting our budget numbers for medical and pharmacy, we are using 40th PCL for medical, and then we are going back to norm on the pharmacy side and using the 50th PCL. And then on the stop loss projections, we are baking in an 8% projected stop loss renewal. We have not got the final numbers on these, but we feel this is a good representation. And then the UHC admin fee guaranteed is guaranteed through 2021, so there's no increase on that. However, we increased the ARC's rebate credit by roughly $3.71 PPM or per employee per month, which translates to roughly 70,000 increase in pharmacy rebates. And then we have our surcharges in here for wellness and smoking at 6% and 14% respectively. In addition, we have our legislative fee with the court fee at an estimated 2.65 per member per year amount. And then we have our final or the current enrollment between the Nexus plan and the Choice Plus plan.
Just a quick, Cynthia Long here, just a quick question on surcharges. What are other plans doing? Are those two of the key areas where people are doing surcharges, or are there other things that are trending?
Yeah, I would say you're probably in the ballpark of what most are doing. And Morgan, you can chime in here after I finish, but wellness surcharges centered around, metabolic syndrome, getting people to get their biometrics done, seeing people who are at risk, how to get their scores back in alignment. I would say that's probably the norm. $100 is probably a little bit on the high side if you just want my honest opinion. But I don't know that you want to decrease them at this side. Something's not motivating people, more people. $100 seems like a much to me. The smoking surcharges are becoming more and more common. That's probably on the high side a little bit too, but certainly permissible.
So is there any, I mean, are there any, because I know in our previous discussion, we talked about engagement. Are there any rewards or surcharges for rewards for engaging, surcharges for not? Or is that not anything he does?
There's different ways to do that. Some of it we talk with Shelley and Rebecca, because where possible, where you can take out the manual element of reporting to try and track certain activities of members that are doing, whether it's an online program or a coaching program that they're accessing or a rally program. All too often, it seems like a lot of information is fed to Shelley and the team, and then they have to sort through based on all the factors who gets the excuse me, lower premium or not. So I think the goal moving forward is to find solutions that you can more easily track some of those engagement pieces, whether it's a coaching piece or an online program. And we've had some preliminary discussions about that, including just. So I guess the short answer is yes, there are other things beyond just the biometrics.
Okay, thanks. And I know COVID has sort of paused our discussions, at least prior to October, for overall employee, wellness and some of the well-being things that we were talking about. But hopefully we'll talk about that at some time as we go through this.
Yeah, and that creates some challenges for just employers trying to, the programs that they have, trying to hold people accountable when they can't even go in to get their biometrics done or go visit their doctor or have a coaching program. So that's an ongoing challenge that many employers are facing, including Holmes Murphy right now, trying to figure out what we're going to require our own employees to do in light of the fact that we've got these barriers in front of us now.
Thanks.
Well, Rebecca, on the FTE positions, I know that's a big issue that we typically look at, and we seem to center on the 1932. Anything additional feedback on that?
Yeah, I don't have anything back on that yet. And Commissioner Long, and if Judge Gravel's on, just for your updates, we put in 10 FTE positions as a holding place. Normally we use the number 40, but we understand that this year there's going to be very few, if not any, new positions added. So we put 10 in just as a holding. We can change that to 0 if we want to, but that's just kind of our placeholder.
Sean, let's keep going.
All right. Here's our fixed cost assumptions. We line item out what is all included in our fiscal year 2021 budget. So on the left-hand side is the current year, 2020 plan year. So in the top section, we have our medical admin for the Nexus plan and choice plan. We said before, it's in the rate guarantee, so there's no increase on that. So we're keeping those flat. And then down below would be the stop loss admin fee for 2020. And then in 2021, we have our 8% load in there for 2021, which roughly equates to around $100,000 increase. And then for our other costs, we have our shared savings piece, which currently is at roughly $300,000 over the last 12 months. I know UHC provided some options that we potentially have removed that for other items. And then I'm just using the last 12 months as a placeholder for 2021 as well, since we have no idea what those claims will be doing going forward. And then we also have our legislative piece included in this. And then down below, we have our pharmacy rebates, which we had an estimated at 1.3 million, which UHC just provided in this presentation a little while ago. I think it was 1.6 million. Well,
yeah, we could when we get into it, we could look at that number. There's some lagging of the rebates of when they're attributed and when they're actually paid. The number that UHC had was $85, Matt. What was just presented a short while ago. Our number out of the gate was very conservative using past rebates. So we can talk through that because it creates an opportunity to create an additional adjustment to the budget. Morgan, do you want to talk? Morgan, you still on with us?
Yeah, absolutely.
I
apologize. The mowers are going to be right outside of my yard. It seems like it just comes right when I'm about to speak, so my apologies. But yeah, this is Morgan Young, and I actually lead our public entity team for Texas. And so happy to be on with y'all today. Wish we could be there in person, but did want to just kind of give you some background of the model that Sean's going to present here in a moment. What we did is we really took a step back and wanted to help you estimate what we anticipated the impact of COVID-19 to be on your population. And so we took all of the information that we have for Williamson County in our data warehouse and really plugged that into this model. And so what you're going to see is obviously based on assumptions of what we know about COVID-19, but it also looks at your population and the folks that have comorbidities, their ages, and then their prevalence for potentially getting this, and then also what it might cost if they ended up in the admission inpatient, and then also correspondingly for the ICU. So I know that United Healthcare has begun producing actual reports that will show how many folks have been diagnosed with COVID-19. And so we're going to take that into account as we look through these projections as well. But this will give you a fairly accurate estimate, at least based on what we know about this, so that we can plug this into our financial estimates.
perfect. Starting in the left-hand chart, this is our estimated cost of hospitalization. As Morgan was saying, we used your actual experience through our CLUE database to get an age distribution for all your members. So we have studies that show that, of course, as age increases, you are more likely to develop or get COVID-19, and then that also increases your hospitalization risk and even with ICU risk. So we have your actual experience, your actual data, and mapped out to those different age bands. And we first start off with a symptomatic infection rate. So we have a range of 1% through 5%, just so you can kind of see a bookends model of what the potential risk could be. Currently, Texas as a whole is only at 0.11% infection rate. New York is the highest of all the states at 1.7% infection rate. So as you can see, that's kind of the range we're talking about. It's more on the lower side than the 10% side, but I wanted to show the possible range of if things went south quickly, then what would that be? So we assess the potential risk of the cost of hospitalization for COVID-19. We use pneumonia as a proxy for COVID-19 treatment. It's the best data that we know right now since it's still early on and there's not much experience through all the actual members that are testing positive. So we use pneumonia as our proxy, and we get this information from our CLUE database that has over 150 clients and over, I think, 400,000 adult member lives. So we have a strong case to show what each cost per hospitalization and cost per ICU admission for this analysis. And we know that the CDC shows a medium length of stay for the estimated length of stay for this COVID-19 is between 10 to 13 medium days. So on a moderate case, we are estimating a 7-day stay, and that would reflect roughly a $34,000 cost per hospitalization on a moderate case. And then on a more severe case with ICU, We are estimating a 14-day stay, which translates to almost $87,000 per admission. So based on your actual age distribution and your members, we multiply that out by the infection rate to get roughly the total gross cost for COVID-19 at the 1% range at roughly 79,000. We have a geographic modifier in there to account for Texas being a little hotter on, or a little more increased cost than the rest of the nation. So that would be the 1% increase. And then we take into consideration the member cost share of what the member would actually pay. And then the plan paid would only be $67,000 for the 1% symptomatic infection rate. I know I just talked a lot. I'm sure there's questions. Any questions on that piece?
No, this is Cynthia Long. My only comment is on testing. Right now, we're doing community-wide testing. And so I know some of our employees are going in and going through that process versus filing insurance against the plan. And so in that, I don't know if you've got testing numbers showing up in any of these yet or not.
We just got some Friday afternoon. I think there's, Caitlin, from what you sent over late Friday from UHC, there was one person that's been tested for a charge of $100, and that's the only related expense that just came through.
Okay, yeah, because we're, or at least I am, and I don't know, Rebecca and Shelley, we can maybe communicate this better, but if our employees do, can direct them to our private testing facilities.
So any question on the hospital?
Comment on that. So.
No, that's helpful. That's good to know. Shelley, you have any other thoughts? You're on mute. There you go.
No, we can get with Rebecca and work on a communication, probably to send out to employees, making them aware of the availability of the testing site versus going through the health plan.
Stan, did you have anything you wanted to add? I see you popped in there.
I don't have anything, no.
Okay, thank you. All right, so that's one part of it. The other part is this other part to the right, which is the deferral piece. You want to talk through that process, Sean?
Yes. So as you were, we're at stay at home, and most of the elective services have been deferred. I know we just started released, or some of those just got released to start doing care now or the last couple of weeks. So there was a couple months where there were no elective services being provided. So we're still early in the game. We don't have April data yet, which is the main month that was hit due to lag of the claims data. But we are estimating, we work with our chief medical officer and our financial team and clinical team, and estimated that there would be a 25% savings on the monthly claims for April, May, and June, and then slowly ramping back up to normal coming in October timeframe. And then based on current industry studies, we're assuming that we would be avoiding 50% of those lost services. So only half the services would come back due to just hospitals only have so many beds. Doctors don't have only so many appointments you can book. So we're anticipating that only the pent-up demand would be hit going into the next fiscal year. So
what's interesting on that is we have seen, so there's studies out there as well of folks that have done white papers after, hurricanes that have hit, and, not the same, but similar situations where there was a deferral of services just because the medical community couldn't perform like they normally do. And in some of those cases, we've seen that, part of that deferred service just doesn't come back. So, as Sean said, we're being very conservative here and assuming that half of that is going to come back. But, as we go through this financial modeling as well, that could be a place that we might change our assumptions somewhat based on the conversations we have. And we may even assume, that a a lesser amount of those deferred services are going to take place in the upcoming months. So that's definitely a point of discussion as we go through this.
So for the current fiscal year, we are estimating that there would be a savings of $1.6 million due to the savings for the April, May, and June. And then if that 50% would come back to next year, there would be a increase or a load to the budget of almost 900,000. But I believe that we discussed, and I believe that we are not including the pent up demand at almost 900,000 in next year's rates currently. Is that correct, David?
Correct. We're talked about if it happens using reserves. So, or on the COVID piece. So we'll get to that when we get to the financial piece.
Okay. And then the last two pieces that are related to COVID estimated costs would be the testing. So we are currently estimating around $70 per participant for a testing piece, but if you were directing them to the private ones, we might need to take that down a little bit, so that could save some. And then the last piece would be, we are estimating a 20% increase in the mental health claims. So mental health claims roughly represent around 2.5% of your overall claims. So our chief medical officer believes that there would be a slight increase in these mental health claims going forward. Any questions on all the pieces in regards to COVID-19? All right. Moving on to our,
This is Judge Gravel. I think the 20% estimate on mental health claims is high for Williamson County because we have been providing mental health care for all of those involved in COVID. And I don't know how high it will be in days ahead, but I feel like the one area that we've really been very proactive is taking care of the mental health of our employees during this. And I think we've done a great job, but I do think that estimate's high. I also think as far as the testing, that there are several more county employees that have been tested that haven't filed claims because they've either been, there've been several with EMS. So there've been quite a few more tested than you guys would know.
No, I think that's a good point. It speaks to the low numbers that just came over on Friday, Judge Gravel. You guys are doing a great job. We can certainly make adjustments to the mental health piece because that's helpful too.
I would chime in just real quick on that, though. I definitely agree. We have really made available counselors, et cetera, to the people that are in the active COVID response. But I think the folks that aren't actively engaged in it, there's increasing issues that we're going to see there. So I'd be a little cautious about reducing that too much if that's what we see trend, because the employees that might have nothing to do with the response, but are at home and their spouse just got laid off or something like that, it's the non-active in the response that I think where we're going to see those spikes.
Makes sense. Sean, you want to go to the next slide? Keep it moving.
Here is our initial 2021 budget projection before any plan design or contribution changes. In the first column, we have our 2020 fiscal year actual budget. And then in the middle column, we have the current reforecast. So this is showing that 1.6 million surplus for the current fiscal year. That is mainly due to the deferral of the elective procedures that we discussed. And then our 2021 fiscal year projection is shown to the right, going up to 26 million. And then down below, you can see what the FTE funding would have needed to go up to account for that projection.
So this is our preliminary. We'll go through the different assumptions on how we got there here in just a few moments. So these are for consumption and consideration. When we met with the smaller team a couple weeks ago, we looked at different considerations on how to offset the increases and how to adjust for all the different changes that were taking place. So Sean, if you can just walk through these for us. If we want to change any of these, we can certainly change these and come back with what the impact is.
Okay. Our first change would be we would like to introduce a new HSA plan and assume 10% enrollment in that plan. I believe the next slide after we walk through this will be the actual plan design, so we can walk through that in one slide. The next would be to increase the deductibles on both the current plans, so the Nexus and Choice plans, up to $2,000. So they are currently at the $1,750, so increasing them $250 to the $2,000 mark. And then based on history and utilization for the emergency room, we believe that the $300 copay right now is kind of light, so we recommend increasing that emergency room copay to $400 to steer services and claimants away from that. And then we would also recommend to change the employer contributions for the tier, all the tiers except the family tiers by 10%, and then to increase the family tiers a little bit more to be more in line with norm around for different counties and different cities around it. We did some benchmarking on that, and it seems the family tier seems to be a little lighter than your peers. And then the last thing would be to discuss the deferred services for future potential claims. We remove those for the 2021 fiscal year and have those potential claims to be paid out by reserves. And then the last piece would be to talk about the Choice Plus out-of-network strategy. We can move on to what our proposed plan design would look like. Here's what the new HSA design would be. So it would be a $3,000 annual deductible. These are individual numbers. Family would be double. And then out-of-pocket max for the individual would be $5,500, and then everything goes to deductible, and then co-insurance for the HSA plan. And then down below, you can see we recommend an HSA deposit for the individual and family tiers of $500.
I'm sorry, this is Cynthia again. On the HSA deposit, I have no idea if there's a norm on that, or where did the 500 come from?
Cynthia, we met as a team, and Morgan, you chime in here as well. We looked at kind of what the benchmarks were and what we call our kind of normative benchmark. What's the norm? And generally, when you introduce a plan like this, you're going to have some seed money that you would include to entice people to join the plan. And 500 just seemed like the right number based on the plan design, and then also balancing out with the other plans. So it was, I would call it more of a normative benchmark. And that could be ongoing, or it could be a one-time, but that's.
I was just thinking that seemed low from my perspective. If for example, the deductible, because at least my thought was long-term, that's gonna be the plan that saves us the most. If trying to get people to consider that one, it seems like I don't know what it would do to the cost, but if we changed that to 1,000, that would basically be the delta between the two out-of-pockets.
So, Cynthia, we had that discussion in our workshop. I had the same concern, and as we spoke through it, the right number is probably $1,000. But we also want to step into this more without overwhelming either our benefits folks or our members. So 500 was one where we could step in, we could get a taste for this for the first year, and then we could start really gearing up and going to the 1,000 if that's what we felt like was necessary. But we didn't want to have a mass migration from either of the other two plans to this, even though the savings would be better. It would overwhelm the management of that, is what the discussion was, if I remember correctly, David.
You're about to say something.
Yeah, I was just going to ask if the, if, and you asked the question, but I don't know that we answered it in terms of, is that initial deposit, if you will, would that be one time, or would that be annually, or what would that look like? And the reason I'm asking is, if, for example, you get, I don't know, 100, 200 of our folks that want to do that one this year, and we decide that makes sense, and then next year we switch it to 1,000, but it's only one time, is that 500 going to be made up next year, or just, you know?
No, all good questions. And to Jay's point, yeah, we talked through this very carefully. We were careful not to kind of shock the system, because it's very different than, as you can see, the other two plan designs. People are going to find out very quickly how much their prescriptions are. That's usually the first thing, the first week of January. And kind of the tiptoe to test the waters first. And as more people enroll, then you can kind of turn up the heat, so to speak, to get more people to migrate here, but slowly. And probably more and more plans probably have closer or getting closer to that, to the $1,000 with some type of incentives tied to getting there, you know, having to do wellness incentives or coaching or what have you. So this is more of a kind of a wading or carefully wading into that pond or pool first. In terms of the ways, and Morgan, I don't know if you're on with us.
Yeah. So I was going to say,
there's what most employers are doing when they start off a plan.
You bet. So what most employers are doing, especially when you start off, and it was a great question. The fact is it a one-time or an annual? Typically it's an annual deposit that you as an employer would do into the account. And then especially for a first year, we see most of our employers putting in that entire amount on day one. I think as that plan continues to evolve, maybe, 2 or 3 years down the road, you could even transition that to have it tied towards your wellness incentive. You might change it to align with your pay periods. But really that first and that second year, while you're trying to get more and more folks into the plan, you want them to have an initial bank of money to be able to pull from on day one, so that if they have to go in and get a prescription or a doctor's visit, they have a cushion from which to pay that. So you could start out year one at 500 and then gradually step that up. And you may tie that to the future. You have to do certain wellness parameters, or you have to, complete a tobacco cessation program if you're a tobacco user. We can tie elements to that to do that step up in the future.
Thanks.
And also the $500, that's what, $80 is $1,000 per, $80 per month. So that's $41. It wouldn't be, to Morgan's point, wouldn't make any sense to spread that out. Now some employers do, but on this initial one, you give them $500 all upfront, January 1.
The other thing that you'll see some employers, we did discuss this, is you'll see some employers that will tier that, and they'll give a different amount for the family versus the individual. And in just discussing that, it sometimes feels to employees that don't cover spouses or children on the plan as if those other employees are getting a better benefit because they carry extra dependents. So it was very purposeful to make it the same amount, whether you're covering yourself or, a spouse or kiddos on the plan.
Also, as you know, Cynthia, on HSAs, they can also, the employee, the member can contribute to that as well. and build up that balance.
Oh, yeah, I mean, that's goes without saying. It just seemed low if, it you know, I'm not sure how much of an incentive it will be, but we'll see.
And that's exactly where our conversation was in the workshop, that, you know, I felt like we needed to do more, but as we discussed it, really, we don't want a great migration to overwhelm the system or overwhelm benefits folks. Or again, it's going to be a new plan. There's going to be a lot of education. There's going to be a lot of questions as we get into it. I think getting, you know, tipping our toes into the water, I think is a good strategy. And we'll just get, you know, they're projecting 10% of the population would be in there. If we get 10% in there, I think that would be a good pilot, so to speak, and then we can move and adjust it from there.
Thanks.
So that's all up for your discussion too.
Jay, I have a question. My question is this: why can't we do both? It seems like we're being more cautious because it's going to be a burden to us as a provider. So why don't we limit the number of people that we allow in the HSA plan and increase the deposit to $1,000? You're saying that really about 200 people is all we can handle the first year. And if that's all we can handle, let's put the limit at that. Let's incentivize it by raising that to what would be wrong with that?
So David, is that legal? You're muted, David.
Apologize for that. It broke up there a little bit, Judge Gravel. Just the adjustment to make the adjustment to $1,000 contribution instead.
I think the follow on to that, though, David, was that if the concern was that we don't want too many to move, can we limit enrollments in the HSA to a number that we're comfortable with?
No, I think that's part of why we're talking about contributions and the seed money. That's where you essentially effectively limit the enrollment, but without telling people we're only going to take the first 100 people that enroll. Once you,
but is that legal though? That was the question. Is it limit? Okay.
No. There's ways to limit the participation. It's through the contributions and the HSA, the plan design. That's really what it comes down to. And, you know, Sean, I know you've got more information to go through, but the actuarial plan value, I think, is really helpful as we look at some of these discussions, because it really tells what percent of the cost the members and the county picks up when people actually use the plan. And people will tend to focus on the copays or the deductible, but we look at everything in total, which is this HSA column. Obviously, there's a lot of things that are going to happen when people use this plan versus the other two plans to the left. But if that seed money is enough and the plan design's adjusted, the out-of-pocket and deductible, it can effectively work very similar to the other two plans. It just requires communication. That's really the key.
Thanks, David.
Sure. You want to keep going on, Sean? We'll come back to this, though, definitely. On? There you go.
2021 projected contribution changes. Top section, these are our monthly contributions. So the first box is 2020 current monthly contributions for the Nexus and Choice plan. And then the gray section would be the 2021 monthly contributions for the Nexus, and then also the new HSA plan. And then the bottom box in that section is the monthly increase for the Nexus and the Choice. And then of course, the new HSA plan would be the same increase because it's a new plan. And then down below would be the per paycheck increase for each of the three plans. David, do you want to talk a little bit how we decided to
Yeah, we looked at some different scenarios because we're trying to balance out and making sure that the budget's balanced. We work with, obviously, with Jay and Shelley and Rebecca and team to kind of walk through what may make the most sense in terms of not shocking the employees, but at the same time getting some of the other plans back in alignment to probably what the benchmark is on some of the family rates. I think Jay, you had made the comment that if you add a child, if you're employee, excuse me, if you are employee and employee plus spouse, and you add a child, then that effectively was a very small increase. What was it, $10? $10. Yeah, $10 to add that. And so the family rates, some of the rate tiers were a little out of line, but at the same time, we want to recognize the impact to the employee. So that was the goal, is looking at the minimal impact to the employee as possible. And you can see the per pay period increase at the bottom based on what we've initially come up with. And we can just keep going through the contributions. If you go to the next page. Yeah, so this is the reforecast with the along with John. Go ahead, Sean.
There you got it. It's the reforecast that includes the plan design that we just walked through, and then the contribution changes that we just walked through as well. So with including these, along with our other assumptions, the FTE funding will need to go up to only 4.7% or $837 FTE.
If you all recall earlier, they had a $901 FTE funding. And if we made no other changes to the rates, the county would have to contribute, or we would ask the county to contribute $901. This way, we're only asking the county to contribute $38 more than they currently are. So really, that's a question that we need to ask you guys as well. What can the county tolerate?
Judge Gravel, the county, it's great to have this discussion, but we're getting toward the lunch hour. And it is my experience as county judge that we always make better decisions when we're not grumpy, and maybe that's more for me than for others. But we do much better in commissioner's court when we go to executive session, because most folks are really surprised. We typically eat first before we do anything. So that might be wisdom.
I think that's great. Yeah, that's great. I think this is a good stopping point, and it kind of goes to my point earlier that we know enough about what we're talking about now and what we're considering that I think if we take 30 minutes to get something to eat, it'll give us a chance to not only digest food but digest this as well, and have a good discussion after lunch.
Absolutely.
30 minutes enough for you guys to get something to eat?
I think so.
Let's be back at 12:30. And
So we're in recess, right, Jay?
We're in recess.
12:30.
Great. We'll connect with y'all in 30 minutes at 12:30. See you soon.
Okay, thanks.
All right, bye-bye.
Ollie, income free.
Who all do we have, Jay?
Cynthia's back.
John's back. John's here.
Morgan's here.
Caitlin's here.
Caitlin, awesome.
Stan's here.
Cynthia's friend Phil is here.
Dr. P, are you here?
Is she able to join us? Is that her that called in? Dr. P?
She shows to be on here, but I don't know if she is there or not. John, are you here?
John's there.
Yeah, I'm here.
And Lisa David, also known as Kathy, is here.
Okay, good deal.
Awesome.
We have a quorum. We have enough people on the other side to answer the questions and record discussion.
Let's regroup if we can, Jay. Everybody's hopefully got something to eat, and we'll go ahead and get started again. Back where we left off about some of the changes that were discussed.
Okay, do you
So back on to have our summary page.
Do you want me to go back, David? Right here.
There we go. Maybe if we can, Sean or Caitlin, go back to page 17. Just to refresh some of the suggested changes that the team had worked with with Jay and his team and Rebecca earlier on. We looked at introducing a new HSA plan. We recommended a $500 initial seed, but we can go back in and show what that would look like if it was changed. Based on that, where the contribution would be set, we're assuming 10% enrollment. The deductibles had not been increased in a while, and while that is a cost shift, it is a savings, and so we modeled that out as well. Emergency rooms, we talked about that with UHC, and more employers are introducing different strategies on emergency rooms to make sure people are aware there are other places for to seek treatment, whether they're through urgent care, convenience care, telehealth. And so the adjustment would be to increase that copay to $400. The contributions, 10% increase on the employee only, employee spouse, and employee child. While the percentage looks high, the dollar amounts themselves are somewhat low. And then the family tiers were significantly out of alignment with kind of a normative benchmark. So we had suggested increasing those. And some of that, it's not just a matter of just making people pay more. When we talked as a committee, we felt that a lot of people, working spouses, were choosing your plan just because it was more reasonable for them to do that than join their own plan as an employee. So that was the logic there. And then deferred services, potential claims were removed. We talked about what that impact is. And we, when we talked with Mel and with the rest of the committee, thought that that may be minimal, but if it does happen, then it could possibly be paid out of reserve. And Mel thought that that was appropriate. And then we talked about the Choice Plus plan and other out-of-network strategies that we can go through in addition. So that's kind of our recap. We want to go back to where we left off, Sean, with the kind of reforecast.
David, just real quick, what are, unless this doesn't have an impact on the budget per se, but what are some of the out-of-network strategies that were discussed regarding Choice?
Yeah, there's a variety of strategies there. And I don't know if the UHC team rejoined, but we looked at eliminating out-of-network care altogether. That can certainly create some noise, require a lot of communication. We looked at indexing to a Medicare reimbursement. For those out-of-network services, that's probably about, if you kind of look at a Medicare equivalent cost for some of those services, for out-of-network, you're probably paying about 500% of Medicare. And we looked, Commissioner Long, at indexing that to 140% of Medicare. That would require some education. There is a savings associated with that that we modeled in. And obviously, the potential issue is balance billing. If currently those providers are being reimbursed at 300 to 500% of Medicare, and you only reimburse up to 140%, the noise comes from the potential balance billing to the members. So it requires some education. It requires, some additional help from UHC, from some concierge services they have to help navigate the employee through those. So we looked at some different things, including, looking at ways to minimize the shared savings expense, and those are the expenses that go back to UHC for those out-of-network claims. So it's a wide range of things. It's a really small number of people, but it does have a meaningful impact.
Thanks.
Sure. Sean, you want to go back to where we were when we left off? Oh, Caitlin's driving. Okay, Caitlin, thank you. We did obviously the reforecast based on the current state, and then we did the projection assuming the plan changes were made. We did also were a bit presumptuous and assume that the FTEs would increase by 10. If that needs to be adjusted, we can do that. And then when we worked with Rebecca and the team previously, we looked at what the county's FTE funding was last year in relationship to the prior year. So the kind of the landing spot was for this, let's kind of work back into what that increase was last year. and the number was in the $36 to $37 increase from the prior year. So we went ahead and used that as our starting point. We can certainly adjust this as needed to kind of come to the projection and make sure everything balances out. Just initial reaction, Judge Gravel, Commissioner Long, as you look at this, or if you have any other comments or feedback you want to give us.
So that's just overall FTE. Was there any, so I guess let me back my question up. Is the assumption that the other costs to the employee in terms of increase for emergency department and deductibles, et cetera, was the only cost that would be passed on to the employee? Because, you know, there's and maybe you're going to show it in a later slide, there's a percentage of employer versus employee that we had shown in the past. And in terms of, I don't want to get so far out of whack where the employer is absorbing it the whole amount. You know which percentage I'm talking about, David?
Yeah. The cost share from a contribution perspective or from a plan design perspective, because we have both.
From a month, you know, from the employee's perspective, it's gonna, you know, on an annual basis, what's that percentage of employer contribution versus employee?
Sean, can you jump to the cost share worksheet that we have? Maybe not in this presentation, if you could pull that up, or if you could share with share on the screen. I know Caitlin's driving here.
Yes, give me 1 second, please.
Yeah, John's going to pull up his worksheet that kind of has all the detail behind it. It's part of our budget model. Caitlin, you can turn the function over to Sean here. There we go. Yeah, so if you will, Sean's going through this, the current cost share, if you look at the, was it 18.6%, 6.6% that the employee pays, Sean?
Correct, yes.
Okay. So Commissioner Long, the number, if you kind of can scroll over to the right, the 2021 recommended contribution is 20.7%. There is an increase from that perspective.
But that's the employer, right?
That's the employee's portion.
Okay. I guess
you're picking, the county's picking up 81%.
Okay, sorry. So it's still close to 80-20.
Yes.
Okay. All right. That's where I was trying to understand. And what overall, and as you look at our market of, you know, comparables, what is that mix for, you know, who we would consider our comparables?
Shelley, do you want to chime in here? We can certainly add our voice as well, but I think you're kind of you're really important in this part.
Well, and I can jump in there too, David. We talked about this in our meeting the other day. As a whole, our employee only plan, when we compare to the market, is still pretty generous, or is slightly higher than the market. Some places are still pretty generous, doing a very inexpensive, you know, a few dollars employee only or covering them. But we're not out of line. You know, our employee only rate is still so low. Where we see that we're out of line is really on our employee plus spouse and then our family plan. We are way lower with our monthly contribution by employees than our peers are. And so that's why whenever we looked at this, we tried to kind of give a little bit of a higher percentage to try to even that out some. As far as what our plan consists of, our deductible is a little on the high end. And I know that we're recommending going up a little bit higher on that for cost savings. But we're also looking at if we do have a potential cost increase for the employee only, employee spouse, employee child, employee family plan, then we do have that HSA option where you can also, when utilized correctly, it's going to save you money, hopefully. So we were thinking it might be kind of a good option this year to go up a little bit on some of our plan choices just to try to be more competitive with what the market's doing, or more comparative with what the market's doing. And we have that HSA plan option that does cut some cost savings if people want to try to be an advocate and do that.
Yeah, to kind of dovetail off Rebecca's comments, Commissioner Long, the plan, while no one wants to increase the deductible, the really employers should look at doing that every few years. There's a leveraging effect that takes place. If you don't increase the deductible, then effectively any trend really gets shifted to the employee because their trend doesn't change because their deductible is the first thing they have to satisfy. And if you think of, when they're actually using the plan, if they go inpatient, outpatient facility, then if their deductible doesn't change from the prior year, then effectively their trend increases zero, and that additional trend gets shifted to the plan sponsor. So there's that leveraging effect that takes place over time if the plan design isn't changed periodically. You don't have to do it every year, but Sean, if you got any other insights on that, since you're the actuary, just please chime in.
I think you touched on that very well, David.
This is Judge Gravel. I have a question, David.
Yes, sir.
The question that I have is I see the figures that are in front of me, but my experience in working with you guys over the last couple of years, you have been off anywhere from $100,000 to $250,000. And it's never you being off in a way that favors the county. It's always you being off in a way that harms the employees. And my question is, these numbers that I have in front of me, how much can I trust them? Are they accurate? Are they close? Or are we going to be off another $100,000, $200,000 here in a couple of weeks?
Yeah, good question. The plan is 100% credible, meaning the numbers are very large. There is going to be volatility in any plan due to large claims primarily. There is some uncertainty when we had looked at the budgets in the past with regard to rebates. We have a little more certainty there. When the projections have been done in the past, we had very limited rebate data, pharmacy rebate data. As you can see now from UHC's presentation, there's a estimated $1.6 million in rebates that come back to the plan. There was some uncertainty on those before because the plan had not gotten a full cycle of mature rebates, and that's kind of what caused some of that, at least last year when we initially did the budgets. I think since we've met as a team and we've gone through this very carefully, that I believe strongly that we've got a better grasp of that. There's some still uncertainty, obviously, due to large claims and other things that we try to predict, but sometimes you just can't predict. I worked at an HMO plan for 10 years in underwriting. Sometimes you just can't predict that $5 million claim, and it does happen. But we've done the best we can based on the information and our process to feel comfortable with what we put out for this estimate.
And Judge,
If I can add to the way we set up our meetings this year, last year we had one meeting in May, and then we got some updated numbers, which I think were April's numbers, and that kind of changed, and we had to kind of scrounge around at the last minute and find some money and figure stuff out. Our hope is that we have this meeting now, and we have another meeting at the end of May. So we come out of today with a really good estimate of what we're doing based on the information we have. We should have those numbers hopefully in by the end of May. And if we have any tweaks or anything, that's something that we communicate to you guys too, and have the final numbers at that second meeting in May. We kind of designed that this year. Hopefully it'll work a little bit better with the process, and whenever the auditor's office gets the claims in and gets them processed, and we have the freshest amount of data to go with.
and I'd like to add also, we have a lot of control over these numbers as far as what we're going to budget. We could choose 50% or 75% percentile as our starting number for our trend, and that would give us a more conservative proposal. We chose to do 40% at this time, which looks like it's a good number, but again, like David said, we go on past experience on what our proposal is. 40% means that 40% of our claims have been in that area. We could go to 75% and have a higher starting number. And then we need to find the revenues to cover that higher starting number. So that's really what it comes down to is how conservative do we want to be on trying to guess what our claims are going to be. Is that an accurate explanation, David?
It is. And Sean, if you want to, or if Caitlin, you can take control back and go back to the look back charts, because I think those are relevant for this discussion. As Judge, one of the things when we had Mel on the phone, we talked about the reserves and other considerations, the reserves the county has in this fund, and looking at where we were budgeting based on where the actuals are. And to that point, Jay had talked about percentiles and trying to project and predict where claims are based on past experience. I mentioned the plan is the large plan is very credible, but Caitlin's pulling up that presentation for us. So I think these charts will help kind of bring back the approach that Jay was just referring to.
David, this is Cynthia again. I think at least, and in my experience hasn't been certainly as long as Jay's on the committee, but I think we've gotten that number tighter over the years and but at the end of the day, that's why, actuaries dig into all the data. I don't know that we're going to get perfect on it, but I wanted to circle back on something I think, Rebecca, you said when we were talking about how we compared with our peers. And you said on our employee only, it was very generous. And I can't remember a total number of people enrolled just in employee only. Is that something that should be tweaked, or did y'all talk about that?
On our employee only, we looked about right. It's the family plan that we're really generous on. Our employee, whenever we look at it, our family premium, and keep in mind, I do take into account that we're on an ACO, we're comparing with all PPOs, and that's valid. But our family premium is $226 a month, and in our market, it ranges from $410 to $866 a month.
A lot of the tweaking on family coverage and employee and spouse was more to do with how it was in relation to single and how it was in relation to employee and children, based actuarially on where those costs are. So to bring it more in line with where the costs are, we needed to increase, or we felt like we needed to increase those a little bit to get that space between employee and spouse, and employee and family, and then those in relation to the other two pieces as well.
Yeah, and if I can add just one other thing, that if you think of the expend here is, I'm not sure if we're having challenges getting the presentation back up on the $250,000. While you want to be as accurate as possible, the plan is of 29 million in total cost. Somebody's getting somebody's feedback. Someone is not speaking. If you could just hit mute, please. Let me help. There we go. Caitlin, are you able to, or take back control of the presentation so we could do the review those look back and kind of just talk through the percentiles. There we go. Caitlin, Sean. There we go. Okay, perfect. Sean, do you want to explain this again? Just bring that, make it to full screen and just kind of go through the process and.
So before we looked at your actual medical experience, this chart represents the rolling 12 per employer per month. So we take your actual experience, which is that yellow gold line, trended 7.6% to today. So we take every point on that dot. So this April 2016, we trended 48 months by 7.5 or 7.6% to today's dollars. And then we are able to put the percentiles on there, which is represented in the past coverage level chart. If we need to be more conservative, we would recommend a higher PCL number. So the purple would represent the 75th PCL, meaning 75% of the time you are below that number. Currently, we're sitting at below the 25th PCL at 767. And currently we selected the 40th PCL, which is at 795, which is loading in around $28 per employer per month to the budget.
Sean, you want to blow up your view because we can't see the whole past coverage, the tail end.
You may just scroll over to the right, Sean, and I think it'll scroll over.
There you go. Thanks, Morgan. Just at the bottom there.
It looks big on my screen, so I guess I can't really see that part.
Use the bar at the, I think the mortgage point at the bar at the bottom, just move over the spreadsheet so we can see the rest of the past coverage level.
I think I'm getting loading issues. I can't really see. You can see, right? Take back over, David. I think I'm having.
Okay.
Technology doesn't want to cooperate, but I think what we're saying here, though, is that there's built-in conservatism to the number that we're projecting right now. And that was very kind of thoughtful in the conversations that we've had over the last few weeks. And so if we need to change that or be more aggressive with our assumptions, we definitely can. But that conservative starting point allows us the capability to make sure that we're not going to miss that number, Judge.
I think going in, again, you know, I'm not the actuary, and nor would you even want me to try to play it on TV. So my questions were just, you know, I know we've got to make some adjustments. I want to make sure we're not pricing ourselves to a place where we still can't attract and retain our employees, but also this making sure that we're kind of going with the market. So my questions are largely answered. You know, I think the bottom line is for the committee, we just have to make a decision of, you know, are we going to recommend a 4.7% increase to the overall county budget to cover this? Jay, what are your thoughts?
My thoughts are, I was in the workshop, so I had the benefit of a little deeper discussion, but my thoughts are this is still fair. I know that we never want to raise rates for our employees. If we can hold everything steady and even reduce them, we'd love to do that. I don't know, you know, that's not practical. And we also try to balance what we ask from the court, because we know that, we don't want to, we want to make sure that we're not overloading the court with the costs. We also have found it throughout the years that if we don't pass on some of those increases to the employees, I don't know, maybe I need to state this positively. When we pass on these increases to the employees, it helps them to understand a little more that costs are increasing. And that's not something that they are not aware of from watching television and the news and what have you. But when we try to hold it steady and they don't experience some of those cost increases, then a lot of times it reflects on accountability and responsibility in the way they utilize their health prevention and health care. I think, but I think the costs here are fair. Only you and Judge Gravel could answer whether the court will, or whether you think the court will allow that 4.7 increase or not.
We can add one thing, Jay. I'd like to just add, when we talked about rebates, because that plays such a big part. When we had met as a team a couple of weeks ago with you and Rebecca and Shelley and the rest of the team, we had a rebate number based on prior rebates from the past year. That number's gone up. As you can see, we had what UHC had projected was 1.6, or actually what was paid. We have additional monies there that were not built in, that we have just learned about. We can factor in that would save some additional costs if we want to. Sean, bring that up and see the impact on the 4.7. So we had $73 per employee per month built in for rebates. UHC's number is closer to 85 now. So Sean, I know I'm kind of putting you on the spot here, but can we, for the benefit of this team, go back to our summary worksheet? If you can take control of the presentation and bring that up.
And as you're doing that, Sean, just a question for the UHC team. I mean, we feel confident in that 85 number, correct?
Hi, this is Matt. Yes, we have minimum rebate guarantees built into our contract, and I believe that number is consistent with what we've projected there.
85, there it is right there. So that's our number that we settled on when we did this originally. So if you take the additional $12, Sean, times the 1571 times 12, that'll give us our additional amount, or just you're factoring in now. There we go. Perfect. $3.2. 3.2.
I like 3.2 better than 4.7.
Me too.
One thing I want to say also, kind of getting back to, are we going to see $100,000 overage or 200,000 or whatever? One thing is we may. One of the considerations we had was, because we don't know if or how much any COVID-19 related costs were going to be, and because we have a $1.6 million extra in our reserve based on people not going to the doctor, not having healthcare costs, we felt like our reserve would be healthy enough to absorb anything we might have COVID-19 related, and therefore we did not include the COVID-19 related items in our budget. So if, depending on what we experience with COVID-19, we may have an overage, or we may come back next year and say, you know what, we had to take $200,000 out of our reserve. But that shouldn't be a surprise, and it should, we don't want to do that. But it's something that, that's a way that we can absorb that cost without increasing our budget based on numbers we don't have a clue about. increasing our costs to either our employees or to the county.
No, Jay, I appreciate that. I think again, the reason 3.2 obviously looks better is that ominous 3.5% revenue cap that's sitting out there that I don't think the legislature is going to budge on, despite what impacts there are to local governments. So I mean, 3.2%, I'm much more comfortable with that, because it sounds like we are pretty, we know based upon our contracts what that rebate's going to be. So if 3.2 is closer to the number, that's great.
Yeah, Commissioner Long, we talked with UHC and Matt chime in. The numbers you had just presented was 1.6. You actually felt they were going to be a little bit higher, but if we just stay at 1.6 as our credit, then that's got a conservatism built into it, where the number could actually be higher. But we want the projected numbers to be the 25 million. We don't want them to be any more. You hope they can be less. The healthcare, there's a lot of uncertainty, but if we can get within 1% of that, that's pretty close. But hopefully, with some conservatism built in, Commissioner Long, Judge Gravel, then we can end up lower than that, barring something extraordinary.
Do any of the other members of the committee, John or Kathy, or Dr. T, don't have any input?
I had a question about the HSA plan, the new proposed plan. And I know we were talking about the $500 seed. Do you expect that if we, and I know we're not probably going to, but for conversation's sake, if we had increased the 500 to 1,000 seed, do you think that would increase the 10% estimated amount that would move to that plan?
Do you want to jump in here and give your feedback on that?
Yeah, and we can actually model out what an increase from the 500 to 1,000 would look like. But you'll find that a lot of folks, it's really going to depend on the education that we do about the plan. So it's especially important to make sure that folks know what they are going to enroll in, and they don't just enroll in the plan just because it's a lower premium. So the educational piece will be the big key. And obviously we've done several implementations of new HSA plans, so we're prepared to put together a robust communication plan and work with Shelley and Rebecca and the team to get that out. But I would anticipate for year one, I don't think that you'd get much higher than probably about a 15% enrollment, just because it is a new plan and it does work differently. And, from an employee and dependent standpoint, it would feel different because, the first time they go to the doctor or get a prescription, they are paying for, the true cost of those services. Discounts from UHC, but it won't be, co-pays like they're used to today. So there will be a learning curve for employees and dependents, but again, we'll do a good job on the education, but I wouldn't anticipate higher than maybe even 15% if you had $1,000 that you were giving into that plan one.
It is such a different philosophy of healthcare. It is what they call consumer driven. So that the consumer has to have more skin in the game, more. They have to pay a lot more attention to what healthcare they're getting and do comparisons and things like that. They become smarter consumers all around. But there's some heartburn, perhaps, just in getting that program going and educating, and then questions as we go along. And it'll be a new plan for not only members to learn, but for our staff to learn. And so Shelley and them will be getting up to speed at the same time those folks are, and they'll be learning things at every step as well.
Jay, I have a question. If we did not offer that HSA plan, would that be a savings on the overall cost? In other words, if we maintain the status quo, would that save us as a county?
David, can you address that?
Yeah, I'm gonna have to point to Sean. Sean, can you go back and look at if the plan had no participation in it and everybody pretty much stayed where they were? Because the plan values and the contributions drive a lot of that. Obviously, you're giving up some revenue because the costs for contributions were lower on the HSA. Within the plan design, it's different than the current state. So if you could, Sean, we may take a moment to pull it up. We can answer the judge's questions.
Actually, revenue ought to increase because they'd be going to a higher cost plan, but our expenses would increase as well.
Yeah, part of the revenue was the increase in contributions though also. But let's go to the plan design piece and let's take out those folks and see what the impact is on the 3.4.
Yeah, it's 3.4. It was 3.2.
Got it.
Still under the 3.5%, Cynthia.
I see that. I think, I mean, I definitely want to leave the HSA in because I think that is something that we need to have and to begin moving towards that. But you know, at this point, unless there's a whole lot other discussion, you know, I'll make a motion of recommending a 3.2% increase. Which I can't remember what the number just went away. $825.
Yeah, 26.
I'm sorry,
26 per FTE.
okay, so it's rounded up. So $826 per FTE for the county side.
No, I think what
Just a $26 increase.
$6
I'm sorry, I thought you said 826. Yeah, it's a $26 increase.
Okay, so does your motion include all the changes in plan design and
all the plan design changes from page 18.
Let's kind of go back over those again, or I guess we're waiting for a second motion, Jay, before I say anything more.
we have a second?
We want to restate the plan. Do we want to restate what the plan changes are? Or are you going to go for a vote? Is that what you're moving towards?
We'll do a summary before we vote. So everybody knows what they're voting on. We do need a second.
Can you guys hear me?
Yes.
We can.
Hey, it's Dr. Palazzo. I've been on the whole time. Y'all, I just couldn't get it to work with the computer. So I'm giving you my second.
Okay. Thank you. Okay, so we have a motion and a second to accept a 3.2% recommendation to the court to increase the court's percentage and everything that goes along with that. And David, if you'll summarize what goes along with that, that'd be great.
And let me interrupt, Jay. I understand 3.2% to the court for an increase. I get that. What is the increase to Shelley and her husband, or Rebecca and her family, or Bill and his family? What's the percentage increase going to be for our employees?
So that's the fourth bullet point down. Is be 10% increase to employee only, employee and spouse, and employee and child. And then employee, the family tiers, employee and family, either the choice plan or the nexus plan goes up either 22% or 17.5%. What was the largest increase on those?
I was going to say, I've got it in front of me, Jay. I can share the dollar increases.
So there we go.
Yeah, it's down here at the bottom. 270 for employees that are on our Nexus, and up to $24 per paycheck for family. And then, of course, it's a little bit higher on the choice plan. Keep in mind, the HSA plan, it shows that dollar increase. It's only because it's a new plan. That would be the amount per paycheck for that plan.
Right.
So I think that for me, at least, the important thing is because percentages, because the amount that the taxpayers of Williamson County, i.e. the county, is paying is a much, much bigger amount. That percentage is going to be smaller. I mean, this bottom chart is on this that we're looking at right now on the bottom of page 19 is what we need to look at, because that's the impact to each individual person versus the percentage impact. And also that percentage impact is going to make a difference depending on which plan the person chooses.
Yeah, so an employee only on a Nexus plan is going to be, theirs is going to increase $2.70 per paycheck. Family on that same plan is going to increase about $25 per paycheck.
And Jay, here's my point. I would rather us not show the percentage increase to the employees, because to Cynthia's point, that's not the percentage increase based upon their salary. It's really granularly. We just need to say to our employees, if you choose the Nexus plan, it's going to be $2.70 per paycheck increase for you. And for Bill and Jill Gravel, it's going to be $10.82 per paycheck. And I think it's better to do that than it is to show a percentage increase to the employees.
And Shelley, correct me if I'm wrong. I think last year or maybe the year before, you all started marketing that way and showed the increases, and we didn't show so much because we had the same concerns. 10%. You know, we were getting well, you're increasing my insurance by 10%, and you're only giving me a 3% raise in that case. So we felt like it was, you know, not trying to be deceitful, but it was better to compare dollars to dollars than percentages to percentages.
Yes, that's correct, Jay. Employees can better understand it that way. That way they want to see the actual, what my rate premium is this, oh, it's going to X. It makes it much cleaner and simpler for them.
And what
that was one of the reasons we had thought about doing the HSA starting that this year as well, just because we don't know if there's going to be a merit recommended this year or not based on the economy and what's going on. So the HSA is an option so that employees are not just taking a decrease to their paycheck. If they would like to, you know, become their health advocate and do that option, there is an option where they wouldn't have a pay cut. Because those of us that were here in 2008, 2009, 2010, we remember there were some years where there was a pay cut, there was no increase.
And then one thing I think we would still need to circle back to on the HSA contribution. Did we on the motion there, was that with consideration there would be a $500 seed money?
That's what we were getting ready to go over, David. If you go back to those bullet points, if we're done with this, is everybody done with the screen?
I want to ask one question because I'm confused. So if I chose the new HSA plan for my wife and I, that would be an increase of $88 per pay period?
No. It's an increase over this year because we don't have it this year. So it's an increase over $0 because we don't have it. If you look at,
it should reflect a decrease.
Yeah, that's really confusing there.
Well, and the problem with putting a decrease is we don't know which plan they're jumping off of. So if you're on the Nexus plan, you know, you'll save from right now $40 a month. If you're on the Choice plan from right now, you'd save, you know, $170 a month. We don't have a way to really make that clear.
I think something may help. Rebecca, if you can go back to our cost share worksheet that we looked at earlier, remember the 18 and the 20% worksheet? Because I think this will help the committee before they if they're trying to see, you know, based on the number, the $26 at 1932, that's around 600,000 increase to the county. If you could value that difference of what the employee's picking up, for the 1,500 people, what is the overall cost that, well, you can take the 197 less the 177 right there, kind of go up a little bit right there, but take that, yeah, there you go, and value what that is from an employee perspective per month. And there you go, perfect. County's going to pick up roughly 600,000. An employee picks up the additional contributions of 371.
I'm good with that. I think the real important thing, back to the question the judge was asking, is if currently on the Nexus plan and it's just you and Jill, you're paying $216 a month. If you switch to the HSA plan, you will be paying $176 a month. But the important thing to emphasize there that we'll need to do as far as the education is I wouldn't bank that. I would increase whatever I'd take that and put it towards your HSA account, as well as we're putting in your FSA before, because you've got to grow that account to be able to get up to that deductible amount. Is that a fair statement?
It is. It is.
Cynthia, I'd be okay with the 3.2. I like that. If we would raise the HSA to $750 versus the $500.
That messes up the numbers and it's not 3.2 anymore.
How much would it mess up the numbers?
Let's see. Don's working on it.
I want my cake and to eat it too, Commissioner.
And I would have said the same thing, Judge, but I think going back to baby stepping into it, and if we encourage our employees to take whatever cost savings they may have had and apply that directly into their HSA, because the other thing to remember is a lot of employees, if you go to the HSA, you're not going to be funding an FSA anymore. You're going to be putting it all into savings account. So if you were doing $200 or $300 a month into your FSA, you're going to switch that over and it's going to start going into your health savings account at that point.
You can keep it, you don't lose it.
Right.
Sean, can you show the plan values and just explain what that is for the 3 different proposed plans? There you go at the bottom on row 52. Explain to the rest of us kind of what all that means.
So the plan values for the current Nexus and Choice plan, they're represented at roughly 82.7%, meaning that you have $1 of healthcare spend, the plan is picking up roughly 83 cents of each dollar. And then for the new HSA plan, the plan will be picking up roughly 76 cents out of the dollar of plan paid or claims paid.
Now, does that include the $750 seed money?
Yes.
Yeah, I think to Commissioner Long's point, it's the consumerism. People start to become better consumers. You'll find out pretty quickly how much your branded drug is, and UHC, if you guys are still on the line, jump in here. But I think this is where consumerism comes in, and I think the value that they get as they become, they could easily not lose anything if they're being wise and better consumers.
I think we're saying that this is the direction that healthcare is going. I think it might be comparable in a pension plan from a defined contribution to a defined benefit plan, where you have a little more control on what your costs are.
Morgan, any other thoughts?
No, I think you guys are asking all the questions in order to reach this decision. At this point, I think y'all are on the right track as far as how to step into an HSA, the questions about the seed money and stuff.
So, Judge, to answer your question, it raises the county contribution by $2 and the rate to 3.6%. From 3.4%.
That's holding at 10% enrollment in that as well.
Okay, the current motion. Let's go back to those bullet points, David, and summarize what's in the motion. Changes are.
You want to put another bullet there, Sean? The HSA enrollment is it includes a $750 seed money.
Well, no, the current motion is at 500. We'd have to amend that motion.
Got it. Okay. Let's hold off there.
I wanted to mention one thing to the committee. It was our intention for this meeting to actually do this review of all these plan proposals and rates and that, and give the committee time to kind of ponder it a bit, and then come back on our May 28th meeting and then have the final motion and recommendation. So I didn't want you to feel like you had to make this decision today. That's why we kind of build in that time frame. Just something to consider.
Well, how about if we do this? We leave it at this current recommendation of that subcommittee, knowing that numbers may change over the next month. We'll have April's data to look at, and if that changes favorably, then we amend that to 750 at that next meeting. But for now we leave it like that, knowing that we've got that as a placeholder. And if we end up with, more data that might push us a different direction, that would be the one thing that we could change. Good path going forward, Shelley?
Yes.
Okay, so we have a motion and a second to do what's in the bullet points. Introducing the new HSA plan with a $500 deposit, whether it's single or family, any of the coverages. Increase the deductible on both of the current plans, the Choice and the Nexus, to $2,000 from $1,750. Increase the emergency room copay to $400 from, I believe it's $300 now. Employee contribution changes, as we discussed, 10% increase to the employee only, employee and spouse, the employee and child, and 22% and 17.5% respectively for the Choice and the Nexus plans to the family tiers. We removed the deferred, this is what we were talking about on the COVID-19. No, we removed the deferred services because we don't know what they are. So if those are higher than our calculated claims, we will be taking those out of reserve because our reserve will have that extra $1.6 million from those deferred services. And then the Choice Plus out of network strategies, gonna elaborate on that any more, or are we okay?
Are there any other questions on that? We talked about the reimbursement at Medicare plus 140%. There's other options as well under the shared savings arrangements with UHC. We also talked about I'm sorry, go ahead.
Did we talk about it, and I might have missed it, I might have been on another phone call, but I know that some companies, if the spouse has insurance with their company, they need to get the insurance there. Did we ever discuss this, about that possibility of us only covering the employee and maybe the children? And if the spouse is covered by their insurance, by their company, they would have to get the insurance there? Was that ever brought up and I missed it?
We did not discuss that today. We've had that discussion a lot. One of the things about increasing the family tiers, I felt like would come into play on people deciding whether they're going to be on our insurance or their spouse's insurance, because that percentage is going to be a little more significant.
Okay.
But we can discuss it.
One other thought. I like Cynthia's idea of let's vote on this where it's at. Let's give another month to look at the data. But I think in the next month, you're going to see that we've had even greater savings than the 1.6 million that's been projected. And if it's greater than 1.6 million, perhaps we could take a part of that to increase the HSA to 500. But one more month of data is always going to be helpful for us in making better and informed decisions.
This is Cynthia again. The other issue, as far as subcommittee, did you guys look at one of the things that I brought up a couple times and we've talked about is our limiting the period of time that retirees can stay on the plan. But knowing that our retirees are a more expensive pool, I think, David, maybe it was you or somebody else said that 5 years was what some folks do. Because right now, if I were to retire at 51, I could continue to pay until I hit Medicare. And that, you know, that's 14, 15 years on the plan. Did the subcommittee talk about, I mean, I'm okay with voting on this, but in terms of other strategies and a plan change, this wouldn't affect the employees, but it would affect our retirees. And that's something that I really think we need to look at, is limiting the length of time retirees can stay on the plan.
Yeah, we didn't discuss that directly. I would like to see some numbers there as to how much that really would. I don't know what the ages of our retirees are or how long they've been on the plans since retirement. Maybe we can get those numbers for our next meeting. That'd be all right.
Jay, we can provide that analysis for the next meeting.
Yeah, if we can look at that, we know exactly what the impact would be.
That'd be great, because I know at least earlier in the year, Julie was concerned on the retiree spend was way above, you know, we'd spent 50% in 3 months, and I just didn't know if that was still going to be a challenge, and did we need to look at that?
Yeah, I would say it's going to continue to be a challenge. I mean, you bring up a good point. Is that, you know, that group's a much smaller group and they're usually sicker, so there's much more volatility and you get much more dramatic swings. So it's not uncommon. I know it's happened in the past, Shelley, where that group exceeded their kind of budgeted allotment, if you will, way before the end of the year. And it's just the nature of the smallness. It's not a fully credible group. So you're going to have those kind of swings, unfortunately.
Yes, we have experienced that, David. It's happened both on the pharmacy side and the medical side.
So I'm okay with voting what we've got before us today, but before we finalize any plan design changes, can we look at that retiree group with the eye that we might limit time on the retiree side to 5 years?
Let's go ahead and vote on this motion in second. Does everybody understand the motion? I'm going to need to see your hands also and your voice when we vote. So all in favor of the motion, say aye. Raise your hand.
Aye.
Aye. Aye.
So it's unanimous. All opposed, same sign. It passes 6-0.
Jay, I have a question, please, if possible. Could we change the semantics where it says 10% increase to employees?
I think there's a couple of things I'd like to do on that, is change that, and also on that line where you saw the difference on the HSA from previous to now, just put an NA on that and not have an amount, because I don't think it's applicable if it wasn't a plan in the past to show what the increase is. Does that make sense?
Yeah, we could also just show, Judge, I think we're all kind of thinking the same way. Just show the cost share going from 18.6% to 20% cost share. The county picks up, you know, basically still 80% of the cost. And it shows, I think that'll help maybe tell the story that you're still picking up the bulk of the cost.
I think in any presentation you all make that I think we need to point that out. What the judge doesn't want to see is the percentages. Yeah.
Yes, sir. Employee cost share from 18.6%. County slash employee cost share. Right. Yeah, county.
David, I think that the chart on page 19, when we talk about contribution, is what we need to show. I mean, that's the explanation right there.
Okay, got it.
And but to Jay's point, take out on the second and third chart, take the dollar amounts out of the monthly dollar increase and the dollar per paycheck on the new HSA plan. I mean, you don't have to do it right there because that's PDF, but when we do the ultimate presentation, just bottoms out.
NA on there.
NA. Got it. Okay.
What's next? Let's see.
Jay, can I ask one question?
Sure.
So our next, when we regroup, really we're looking at up, and Commissioner Long and Judge Gravel, hold me honest. When we regroup, we're looking at updated claim experience, and we're considering the 750 on the HSA plan, correct? That are really our only two things to look at, or?
Well, and also the, and again, I don't know that it's going to make any difference on plan changes per se, but it might look at the retiree piece, and that would just be a policy change, but do we make that policy change?
Okay. And David, concludes your presentation. Is that right? I know we have a thing on here for navigate plan design. Does anybody really want to consider that this year with all the other changes? And I guess maybe you can introduce what the navigate is.
UHC, are you guys still on the line? I mean, I can take it, but if you're on the line, I think it'd be helpful.
I think with the motion we've just had,
We're here.
We're not really going to consider navigate, but we could.
Not this year, Joe.
Okay.
We're here.
So I do have a quick question. There's, you know, the ACO that we're in, there's others getting into that market. And when's that contract up? Next year? I can't remember.
Yes, that's correct, Commissioner.
So I think introducing a lot more changes, given that that in the 2021-22 fiscal year will be up for consideration. I think looking at potential other changes in, but I'm pretty confident there's going to be more people in the ACO market at that point in time that we need to look at.
Yeah, we talked to UHC. You want to just give a kind of quick editorial on that? Because I know we talked about that exact issue on Friday.
Sure. This is Matt. So we are in active negotiations with another hospital system outside of Seton to develop a similar program. We anticipate that it will be ready potentially for 2021, but we're still ironing out the details. So we don't have a lot of specifics that we can share at this point. But to your point, Commissioner, we will have more options going forward in future plan years.
That's great. Thanks.
David, I apologize, we were on mute. Do we want to talk about Navigate just real quick, or are you guys thinking?
I don't know, Jay. I'm not sure if I understood we were not going to talk about it or not. Or do we want to at least explore the network considerations? I know Shelley's team still has some issues with Nexus.
Well, it wouldn't hurt to get a little bit more information if that's a relatively quick presentation.
Yeah, we talked with UHC. Obviously, Shelley and her team continue to have some issues with the Nexus plan, turnover, other member-related issues. So we explored looking at open access model architecture, if you will, similar to what you have on your Choice Plus plan. So the challenge there is, there's pretty significant savings from Nexus, and it was going to add about $1 million extra. We did have another alternative that we looked at, which is still a cost increase. It's called Navigate, and requires a PCP selection. It's about a $300,000 load to include that, and requires some additional communication. But Matt, I know I'm probably not doing it justice, but you want to go ahead and give a quick overview, you or Lori or Tanya, on Navigate?
Sure, I'll kick us off, and then please, Tanya and Lori, please feel free to jump in. So Navigate, as David mentioned, is basically the current plan design, but you have a gatekeeper requirement, which means that if a member wants to, so a member has to choose a primary care physician, and the primary care physician is responsible for guiding members throughout their healthcare experience. Part of that guidance is a requirement that the PCP provide a referral when a member wants to see a specialist. So on one hand, in my mind, it's a positive because the county has always really pushed the importance of the primary care relationship and really understands and wants members to have that in place. On the other hand, it does have that additional requirement that members do go to their PCP before they go to a specialist, and that the PCP, primary care physician, enters in a referral before the member can go to the specialist. So a little bit more of an administrative burden, but the guiding principle is that PCP needs to be involved in the process. We don't have that under either of the current plans. By putting that program in place, we could remove the tiering from the Nexus program so that the Nexus plan would not have Tier 1 and Tier 2 benefits for in-network providers. Instead, they would all have a consistent level of benefits comparable to Tier 1 benefits right now, the higher level of benefits. But we would need to put that primary care referral component in place to help control those costs. And when we looked at it, as David mentioned, it does increase costs about $300,000 when we do that. So it'd be, we think it would alleviate a lot of the concerns that we've had with the Nexus program, with the practice patterns and referral patterns within, and members kind of falling through the cracks from Tier 1 to Tier 2 level of benefits. But it does add that additional administrative component, the referral requirement.
I think if I understand it correctly, it reminds me of the old HMO model that, my primary care was the gatekeeper on everything, and which is a good thing for the plan. It's not necessarily the best employee experience.
I'm sorry.
No, I was just going to say, but if our model is that we're trying to help our employees become better consumers and take more control, that almost seems like a bit of a step backwards if we're pushing more and more the HSA model, where our employees have to own that a little bit more. I don't know. Maybe I'm misinterpreting.
Well,
no, I agree with you completely, Cynthia. As a physician, we hated that model, being the gatekeeper. It was a lot of administrative work. And as a patient, the patients hated that. It takes away their autonomy. It takes away their choice. And I'm completely against that, just from a doctor's point of view, as well as a patient's point of view. I don't like it.
Tell us how you really feel, Lori. So I appreciate you covering that, but I think given that we know we're going to need to renegotiate and deal with it next year, I'd say we live with what we've got for another year.
Well, and we just wanted to offer an option. We know that there have been some issues of the nexus that have not been ideal. This was an option that we wanted to bring forward that would help take care of those some of those concerns at a relatively cost neutral basis. So appreciate you listening to mine or hearing mine.
I appreciate you bringing it forward because you heard us complain and you responded. So thanks.
Yep. Thank you.
I think Shelley, did you want to say anything on that? Because I think that was something that was going to address some of the issues you all have experienced. Is that right?
Yes, Jay. Our whole intention was we've been still experiencing problems with the ACO. It's not a stable network. The instability, the access to care. When a member tries to do everything the right way, it still goes wrong. And this was just, we had reached out to both Holmes Murphy and United Healthcare to say, what else can we do? Because some of the things that were occurring are beyond the member control and our control. And it still goes on. We've lived this Seton plan now for 6 years, and it still hasn't gotten any better. So I'm very excited to hear that what I heard Matt speak about earlier, that there are other hospital getting into this type of narrow network or a network at all, just so that it will better service our members. Or even I'm hopeful that maybe in the coming years for people that whether they don't go on the HSA, maybe they'll just have a straight PPO plan to give the member choice and most importantly, access to care.
Okay. Anybody have any questions on that or? Okay. Let's move on then. So, David, is that complete? Holmes Murphy and United Healthcare? You might be on mute. If you're...
Yes, Jay, it does. I'm sorry.
Okay, thank you. Okay, let's move on to number 4, discuss, consider, and take appropriate action regarding the timeline for the 2020 wellness actions to be completed by employees, retirees, and covered spouses. Shelley, is this yours?
Yes, it is. I just wanted to bring this to the attention of the committee because I've had several employees, as you can imagine, especially with COVID-19, reach out to me. They're very concerned about their ability to be able to complete their wellness actions even by the November 30th date. What's happened is many members may have had an appointment scheduled, and due to COVID, those appointments have been rescheduled or put off to a later date. From my own personal experience, I have completed my wellness exam, and it was through Skype, through my physician's office. It was relatively simple. I did my own temperature, my weight check, my blood pressure check. I did all of that myself. And I simply am going to go make my appointment to do my biometric screening at the CPL lab. She has the form, I've emailed it to her, and that will get completed. Well, that may not be the same scenario case for all of our members. It just depends on the medical provider office if they have those capabilities. So Rebecca and I and the team, we spoke about this, and we thought, well, what if we recommend to the committee, even if we add an additional month? So currently they have until November 30th, but what would the committee consider even extending that date out to December 31st? That we don't have a second wave of COVID, and that would add to, then that would be a whole nother decision for the committee. But to be responsive to our members, I'm very concerned that some of them, are really just struggling with that.
Shelley, if one of the things, and UHC pointed this out at one of our more recent meetings, I think a lot of employees are under the impression that they have to wait a full year before their next so like if I didn't go to the doctor till October, they think they have to wait till then. And UHC made it very clear that they don't enforce that. And so I think communicating that and letting our members know, schedule it now, even though your time might be October, would be really helpful.
Commissioner, one thing to that, we know we do our best to communicate that. The problem that we run into is some of our big primary care providers like Austin Regional Clinic and a couple others, they have their own individual billing practices. So they are the ones that are giving the pushback to our members. They literally will not schedule them because of their own individual billing practice. We've even, myself and my team, we've gotten on the phone. We've had Lori and her team reach out to the provider. But some of those provider offices, they're not going to change their own respective billing. So we can do that, another communication or follow-up, or even work with United Healthcare to do that. But we're still going to bump into that medical provider office and their roles, their scheduling. So that's.
I'll call Norm Shinben with Austin Regional and talk to him personally to see if he can work with us on that.
That would be very helpful because we pretty much direct a lot of our members to Austin Regional Clinic just because of their locations, their accessibility, well, outside of COVID, but pretty much are the #1 big provider group that we refer folks to.
Actually, I'll see him or I'll be in a meeting with him on Thursday, so I'll talk to him.
Awesome, thank you so much.
I do like the idea of a virtual wellness exam because I think I would probably lose 10 pounds.
Jay, if you just cut your hair, you'll lose 4.
Well, I was appreciative, let's just say, of not having to go in. I'm, pretty healthy right now, and I just really was not looking forward to going in. So it was a quick visit. It was 30 minutes. I had to do a little bit more work myself, but all in all, is relatively painless. So I see that, I'm sure more offices, and mine's a Seton provider, so I'm sure more Seton offices are going to offer that. I don't know if ARC, that could be a question, Commissioner, ARC, to not only to help us out on the timeliness of scheduling appointments, but are they embracing that technology to do those type of wellness visits?
I'll get with you before I see Norm on Thursday, Shelley, to make sure I get all the questions.
Okay, very good.
So somebody, are you recommending that we extend it a month, or was that just a inquiry?
I'm asking the committee if they will consider that. I think at least by, what do you think, Rebecca? At least by giving an additional 30 days, we've, extended a little bit out. Hopefully some appointment times will be releasing for those members, so they'll know they have the time just to get their wellness actions completed.
Yeah, I think that would help. And last year we did get some pushback having that last date be the end of the month of November, because that last week in November, most all offices were closed anyways for Thanksgiving. And a few people got into binds and, tried to turn in labs, 12/1 or 12/2. Of course, we couldn't accept those.
How does that affect your administration of the discounts?
Well, so what it would do is we would work with United Healthcare. We'd have to make that update through the system. Lori, I think Lori Messina's on the line. So just have to get that programmed in the Valley portal. But on the reporting side, it would extend the timeline that we would get the actual completion of the wellness actions. Just as an FYI, wellness action surcharges are being applied this month. So it takes that time to get all of those pieces back from UHC in order to reach out to members and then apply surcharges. So it would push that out about a 30-day time period. Lori, can you speak to if this is something that we would be able to update in the Rally system relatively seamlessly, and then we can do a communication out to our members as we typically do to remind them, but at least it would give them some ease on their mind.
Yes, we can absolutely make that update. We just, once you guys confirm what you want it to be, we'll submit it through so that it's updated. It does take about 30 days, I think, for it to be viewable out there for folks to see it on Rally once we decide. And then the other key is to make sure there are internal kind of checks and balances are lined up as well. But what we can absolutely accommodate once you guys decide what you want to do.
One question I had was, David, I remember we talked in our meeting a few weeks ago about not accounting for any of those wellness surcharge amounts in our budget. Because one, we weren't sure, we have such a lag to actually get them done. It's normally the end of May or June to get the numbers in for part of the year. And then two, depending on what's going on with COVID, we may not have those in some form or not. And we may not have a surcharge at all next year, just depending on what happens in the fall. Were those taken out or were those still in our budget?
They're still in. So we need to, if the plans change, or we need to definitely account for that.
Maybe if we want to think on that and bring that to the end of May, that is one of the items as well. If we do decide, that gives us a few more weeks to think about it, but we might need to take that, whatever was in there for those wellness surcharges, completely out. And just, if we get that, it's a bonus and not count on it.
Got it. Making note of it.
Okay, me too.
Okay, does anybody want to make a motion in that respect?
Jay, I make a motion that we extend wellness checks 30 days.
We have a second?
I'll second it.
Okay. Motion by Judge Gravel, second by John. We extend the wellness deadlines by 1 month to December 31st. All in favor, say aye. Raise your hand.
Aye.
All opposed, like sign. Passes 6-0. Okay. Number 5, discuss, consider, and take appropriate action regarding the Williamson County Wellness Committee.
Okay, I can start off with this, but then maybe Commissioner Dr. Palazzo would like to comment on this as well. The Wilco Wellness Committee did have a kickoff meeting, and we had some great discussion. We came out of it with talking about what the purpose is going to be and where we wanted to go. So we identified a couple key identified parameters to move forward. One was to identify our wellness goals. What are our top 3? Creating an employee survey, and then identifying a wellness budget for implementation of programs. So then, unfortunately, COVID-19 hit, so we did not get to move forward with creating the employee survey. Our intention was to partner with both United Healthcare and Holmes Murphy on creating that survey. And we also came up with the reason for creating our wellness program are to reduce costs for both the employer and the employee, improve employee overall health and well-being, and increased productivity. So I'll defer to Commissioner or Dr. Palazzo if they have some additional that they wanted to add to that.
No, Shelley, I agree. I mean, we had a good meeting. I think it was either the end of February, 1st of March. I can't remember when that was, but I think realistically, knowing the extra burden that the folks on that committee have taken on because of COVID, as well as HR, I mean, I think that until we, if we choose to put that person in the budget this year or reconfigure a position in the budget, that seems to be honestly what we need to do first, because without a person to really focus on that as their primary goal, I mean, everybody else on this call today has taken on additional responsibilities right now. And I know very few of us have any extra bandwidth, and until we have a person to focus on it, I mean, I think that's our next step forward when we talk about the overall benefits committee budget is, you know, to me, that's the recommendation, is that the person, whatever that title needs to be, you know, well-being coordinator or whatever, until that person's on board, I don't see that anybody has the bandwidth to take it on and be successful, because you don't want to start it and not be successful.
Right. And that was a good segue, Commissioner Long, into what I had on this item was, if you guys, we currently do have a well-being coordinator in our budget request. Obviously that was put in back in February before all this happened. If it's the committee's desire, I can leave it in the budget request, or if like me to forego that request, I can email Ashley and ask her to pull that.
I think for we leave it in, because my goal is that as we've retooled just our entire workforce and we have more folks working from home and working differently, that there may be positions and budgets or in different departments that we maybe can move around and still accomplish our goal of not adding new employees. Leave it in there for now. At least that's my thought.
And I did see this pretty integral with us starting an HSA, just because that's somebody else to do education and well-being and, you know, getting our employees to be their own health advocates. That's going to be a big focus on this position.
And I think this is the key to our success in wellness, period.
Rebecca, you said that position was in your budget. Is that position considered in the overall overhead that we charge back to benefits in what we just made motions on?
Yes, it is.
So Jay, do you want a motion on that?
I don't know that we need a motion. We already had a motion earlier to put it in there. I don't think we did any action on this. I think it's more of a report. Anything else on the wellness committee?
No, that's it for now.
Thank you for that. Number 6, discuss, consider, and take appropriate action regarding United Healthcare pharmacy updates and changes to the formulary that often occur throughout the benefit plan year.
We wanted to bring this to the committee because typically we get the pharmacy updates from UHC. We approve the new PDL Advantage, I think it's the Advantage tier plan that we're doing. And then right after that was implemented, we got a pharmacy update from UHC, and we got this long report and list. And we were given the option to either review, opt in for these changes or opt out. So Rebecca and I reached out to Dr. Palazzo and reviewed this list with her, and together the three of us went through it, and there were some things that made sense. Yes, we opted in. There were some things, the savings, it wasn't really there, so it didn't make sense to do that. And there was a huge impact, there would have been a bigger impact to some of our diabetics that we had already impacted beginning January 1. So we thought it would be good to bring to the committee to get your feedback on this, is as these changes come up after the committee's already reviewed any benefit plan changes that you've already approved, are you good with us reviewing any other as they come up throughout the year, pharmacy changes with Dr. Palazzo? Let her review, and then that way she can advise us on how to respond. Because the timing of these, when they happen, they don't always fall in when we're having a benefit committee meeting. And sometimes we have to, you know, give an answer before the meeting. So we wanted to present that to the committee to see if that was something that they were good with. And we feel comfortable with having Dr. Palazzo review those, and then knowing more in-depth knowledge about the changes and the medication protocols that UHC is asking us to either approve or not accept.
Anybody have any feelings one way or the other? Sound like it. I'm good with you all taking those changes, but I'm one vote.
Yeah, I'm good with it as long as Dr. Palazzo is involved. If there's anybody I've learned to trust immensely in the last 60 or 90 days, it's Lord Palazzo, if he has the bandwidth to do that.
I do, Judge. I'll be glad to do it. I don't have a problem at all.
So I guess my question on that topic is, yeah, there's changes, but I mean, it's hard for me to weigh in one way or the other because I don't know what they are at this point.
Well, I'm sorry, Commissioner, I didn't provide the changes. I can do that going forward. I can pull those up and share those with the committee as they happen to know, and at least give the committee the update that this was the changes that we had to respond to, whether to accept or to not accept. And this was the decision that we made. So what we can do is provide that list to you going forward.
Yeah, because I mean, I appreciate that, but if I don't know what it is, I can't weigh in as to whether that's a good thing or not if I haven't seen it.
Shelley, do you want me to jump in here for a second? These are, just to clarify, so these are what Jack was talking about on the earlier presentation. So we review the pharmacy list, and we've actually just moved to reviewing it 3 times per year. And so our Pharmacy and Therapeutics Committee makes recommendations on coverage tier changes, coverage exclusions based on new medications coming to market, based on patents being removed, generics coming into play. So we're constantly reviewing the drugs that are available that provide the most cost-effective but best treatment for the members. So, but as an ASO client, you can certainly review those and you can accept or reject our recommendations. And it's just it's a new list every time. And in fact, I'm getting ready to send another list to Shelley where we need decisions by June 1st. So, and the timeframes are usually 2 to 3 weeks for us to get it and have a decision back. So I think that's where the struggle is coming from, with Shelley being able to present it to the committee.
Yeah, no, I'm not suggesting that the whole committee weigh in on that. I know it happened because I had a drug that got cheaper.
That's good.
But you know, but again, the agenda item says discuss and take appropriate action, but I can't vote on taking action on something I know nothing about. So I guess is my point. But I'm happy to not dive in. If you could just send me the list, that would suffice my bizarre need for more information.
Okay.
Do we have a motion?
So move.
Okay. Is there a second?
I'll second. This is Kathy.
There's a motion.
So clarify what the motion is, Jay.
That's what I'm going to do. There's a motion and a second to give authority to Shelley and Dr. Palazzo and Rebecca to review the formulary changes that come out 3 times a year from United Healthcare and make a decision on our behalf as to which changes to accept and which ones.
And this doesn't have to be a friendly amendment, but just from a process perspective, I think that list needs to be sent to the entire committee at the same time it's sent to those 3. That way, if any of us, for whatever reason, want to weigh in, we can at least communicate that to one of those 3 before they make that decision.
So that's probably a good idea.
Jay, one moment. Who made the initial motion?
Judge Gravel. And Kathy Mendoza seconded. Okay, does everybody understand the motion? In favor, say aye and raise your hand.
Aye.
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 All opposed, like sign. Passes 6-0. Number 7.
Give me just a moment to get to that report. Just wanted to these are the financial report as of March. You can see that we have in assets 4,564,000. I think Rebecca had chimed in earlier from Julie that we are anticipated having 3 million in the reserve fund. Is that right, Rebecca?
Yeah, she was estimating roughly 3.1 million. We ended last fiscal year with just under 2.4 million. And that's not anticipating what we have seen. You know, we haven't really seen COVID effects yet because that would be more April, May, June cancellations.
Any questions?
Questions on that?
There was no motion on this, just to
just review it.
And then one other thing I just wanted to review with the committee. I've made some updates to our benefit committee calendar year plan. Presently, we are still moving forward. We will have our next benefit committee meeting on May 28th. I anticipate with some of the decisions made here that I believe that could probably be a half-day meeting. David, Rebecca, do you think we should be able to facilitate that versus a full day?
Yeah, I think so. I mean, I'll defer to Rebecca, but.
No, I would agree. I said we can start at 9 and maybe just set it till, noon with hopes that we'd be out a little bit even before that.
I would agree.
Very good. And that will be another virtual WebEx meeting.
Anybody opposed to having a shorter meeting? Seeing none.
No, I want to spend more time on a WebEx.
I was going to say mute everybody, Jay.
There you go. And then we're looking to having our third quarter. At this time, it potentially could be virtual. I'm just going with that plan. And then once, so before I go any further, once we have our May 28th meeting, then Rebecca and I are already on schedule to meet with the other commissioners prior to Commissioners Court. I believe we're in Commissioners Court on June, I think it's June 23rd. That date is telling me when we're there to present everything to get approval for plans, rates, any plan designs to get approval. And then we begin the very busy activity of preparing our communications. I've been talking closely with the benefits team, and this year we're planning on having open enrollment meetings, but it all depends on if we're able to meet. If not, then we're going to have to move to probably more webinar meetings. So it's hard to say what's going to happen between now and then, but it's kind of what we're planning. And then
I would recommend that even if it's open to where you can meet in person, I think the webinar meetings are still a good offering to people who at least give them another option.
Yeah, and we've got we've got our computer equipment that we ordered for the respectful workplace training and everything. So we've now got stuff that we're doing online and doing trainings online. So we can even set something up into addition to what Lori does. We thought about kind of like a Q&A, kind of top 10 list of some questions we think will come in, and somebody asking the question and somebody answering it, just kind of a live one with that. We may also look at less locations. Some of the locations when we go out to county offices, it's really small spaces and the room may be packed. So we may say if you're going to come in person, it has to be at the Georgetown Annex because we can do distancing, limit signups, and we'll get creative with everything and do whatever we can to make sure we keep everybody healthy and still informed.
Yeah, we still need to practice the distancing.
Absolutely.
Safe practices.
And not knowing how long this is I'm also planning as a backup to having an in-person benefit fair to having a virtual benefit fair. So Jay, I've already had a couple conversations with Rory and Jim, in fact, and so they're probably going to be discussing some potential to do a virtual benefit fair. Because the main reason for the benefit fair is engagement, education, and to get employees and members to the point so that they feel fully informed when they get ready and to complete enrollment. So there's that potential that we may not have an in-person benefit fair, but it will be more of a virtual.
I'm looking forward to the virtual massage.
I'm with Jay. I'm like, there's some things that.
Yes, Jay,
you can't do virtually.
Jay, take your arm and pat yourself on the back and start rubbing. There you go.
There you go. So, anyway, so those are some things that we're working on. So more to come. So
I want to interject a thought here, Sheldon. I think we really, something that I've seen in the last 2 weeks is what I call consumer confidence. Even though we've changed our rules and how we function as a county and lifting the stay home, stay safe order with the governor's new rules, what I am seeing is that there is no consumer confidence right now. In other words, I went to Longhorn Steakhouse that did an amazing job in how they took care of us. But we were only one of 3 tables in the entire place for noon lunch. And the reason I'm telling you that story is I think you should plan everything from this point forward to be done virtually. The thought of doing something in person, I'm not sure people are going to show up for it. The confidence level is very low, and I know we've got to get back to that, but we just live in a different world now than we did 6 months ago. And we ought to be thinking about how we roll out our benefits, virtually and in every alternate form. We need to forget how we've done it in the past because we've reinvented ourselves. We're going to have to continue to evolve in the benefits area for employees.
Right. And Shelley and I've even talked about doing similar to like a BOMGAR, because and I wish that Taryn was on here so we could discuss it. The Road and Bridge crowd is one of the biggest ones that really requires a lot of hand holding during the registration process, and why we have a lot of the on-site counselors here. And so perhaps, we just share a screen. They're on a computer. We can still guide them through everything, talk to them on the phone and kind of walk them through things. So we're looking at anything we can do to be creative. We've had a lot of brainstorming sessions.
and in fact, instead of on-site enrollers, we're talking with Vincent Benefits on opening up. They have a call center that assists also employees to help them enroll. So I think the key part is having a virtual communication strategy. We are looking at, hopefully, we'll have some additional communication tools and educating people and then getting them through that enrollment window.
Well, I would invite you to look at what it is you need. All of those things that you've talked about could qualify, at least it's my understanding that they could qualify for the CARES funding. So if we need to buy more BOMGAR licenses for that, if we need to buy more equipment, whatever it is, get that together, at least the numbers together, so that we can go ahead and start getting quotes and start making those plans. And I think the funding will be there.
Okay, great. I'll get with Rory's been a tremendous help with that. So I'll connect with him.
And I think Judge Gravel had a good point. We need to plan for everything virtual. And if we're able to do something, again, it's a bonus if we can do anything in person.
Very good.
Well, I know we're taking a spreadsheet, or at least an ask to court next Tuesday. Not tomorrow, but next Tuesday. So if you can get something together, or at least discuss with Rory, we can get that, make sure it's included in our ask.
Okay, I will do that.
Okay, anything else?
That includes, we will have our next meeting on May 28th virtual, and we will do it from a 9 to
May 28th, that's 2.5 weeks, 2 weeks from Thursday, right? Okay. Well, thank you all. I know this was a tremendous amount of fun and excitement, especially doing it virtually. And I didn't see too many people. I don't know. I think most of the time when you muted your camera, it was because you were nodding off. But I think there was good participation. I think we made some good decisions today. Continue to think about what we passed today as far as plan design and all that, because we're going to revisit that in 2.5 weeks. So thank you all.
All right, thank you.
Thank you.
Thanks very much.
Thanks, Jay.
Thanks, everybody. Have a great day.
What? You can't. Yeah. Well, because Rebecca said, send that. And I was trying to send it to people and it didn't work. I think it's tearing this down. And I'm just like, oh. So. And they're stuck. Well, yeah, there's, so I think we can, begin working on the FAQs on what if, and, you know what I'm saying? Then we can get with Rebecca on, what they're using, yeah. What I'll do is, I will send, message on, okay, here's what we think we're gonna need, right? He sent me an email about some, he sent me a couple things. What about this? What about that? I'm like, okay, now it sounds like we need to get it all inclusive, because if we can get any of this covered by COVID, now the one thing I've got to do is got to reach out to Chris and Kathy. I'm thinking this year that we're going to have to not have the benefit fair. Yeah. And I'll have to get with Dr. Plazo, like, how do we, let's think differently on how, remember we've talked about how we do flu shots, on-site flu shots. You know, I just, yeah. No, I was like, yeah. I really thought we were going to get more pushback. Well, here's what I'm concerned about. Tearing that there. I'm like, so yeah, because he's gonna So I'm gonna reach out to him because on May 28th, 30 minutes. So this is the plan. This is online. Everything is. Yeah, I was surprised. I just wanted to lay that. Hey, you guys didn't have to make this today, but you're going to. That's good. Yeah. Well, in my perfect world, they did exactly what they should do. Like that's how it should be. They should say, "This is what we want." Yep. You know, there may be a slight tweak or adjustment based on numbers. I want them to acknowledge that, right? That's what didn't happen. And you got those numbers in them. And I'm like, we've already voted on this. We can't change this. So they gave us direction. The April numbers in. Maybe a few tweaks here and there. And I'm worried. Why did David put surcharges in the new budget? How many times? So I made a note on my thing whenever I saw that. I am just, yeah. And so I'm like, but then again, because I missed yeah. Well, I think surcharge money should be, hey, if we get it, it goes into reserves. And the nicotine to me, that's a little bit more set. Yeah. I know pretty much going to be the same people every year, but this, yeah. And that's what I think going forward, we don't count on. We need to build up our reserve. Yeah, I guess when I can always, I need to reach out to Dr. Plaza separately too. So on this virtual benefit fair, Rory and I, we were talking about some things when he was getting us set up for WebEx. I was asking him some questions on, hey, so if I need to do this benefit fair virtual, and he had some thoughts, and then we were talking about, oh, can I do flu shots? Maybe this mobile unit could go around. I'm like, yeah, or you know what, we could maybe still, maybe Dr. Pleasant, I don't know.
To me, we just send out a map of this. Here's where you can get them.
Go to these.
Here's HEB, here's this,
Yeah.
here's this. Because yes, I know they can look on the phone.
So then what I thought of is how we design this. I was just thinking, okay, here's what I'm thinking. Everybody, they sign in, they get educated, they go to room to room to room. And if there's a way we can see who went to and completed it, and then maybe whatever swag item that we pick out, then it gets mailed to their house.
Some sort of virtual.
Yes. And so Rory said, this is not a bad idea, because think of all those people that don't get to come or they can't come because of their bosses. This gives a way, and is this?
I'm just gonna say, we're not gonna.
Yeah, I think.
To make the plans, we have to be really sure by August. If there's a second wave of this, it's not gonna start.
That's the other
until
thing. Yeah.
And we can't cancel last minute. I mean, we're gonna have all.
Yeah.
I think Judge Rebel's point was very well taken.
Yeah.
We just need to
That's
right. And the benefits very, it may be very scaled down or very.
It's a virtual,
But
but
we'll see what we can do.
But if they can visit the rooms, and then I was thinking of, okay, so the vendors, maybe we don't have as many vendors participate. Maybe it's just a few. And
we acknowledge them, list links to their websites.
Now,
similar to what you see, like when you go to a rodeo, and then there's a sign. Here are our sponsors. Here's the gold level. Here's the
right.
I guess we can have a red hat.
Oh, yeah.
Here's a red level.
There you go. Red level, yeah. And then.
And we can do it in that order. Always red, white, blue. That's how you say it. That makes Republicans first and Democrats last. That's the order.
That's the order. That's the way it goes. Yeah, so I'm just thinking, I haven't called Chris and Kathy yet. They've got to be aware of this. So I think I'll reach out to them. I already spoke to Winston on the call to, hey, tell Curry that we're going to be interested in the call center. That will help people. And if we can get the bum guard for Suzanne, myself, and Miranda.
If you go around the rooms for the flag, and to me, it wouldn't be the tickets like we normally do. You go around to the rooms and you get your swag bags in, you get a ticket. Everybody just gets one.
Oh, yeah.
And we have drawings for prices.
There you go. Yeah.
Everybody gets tickets.
And I guess we could be thinking about that instead of getting big prizes this year. We could just do gift cards. Hey, then we can send the gift card.
Those are easier to mail out.
Yeah. So yeah, just have to think of it a little bit differently. Yeah, it's like.
We don't want anyone. First, we can also ship from Amazon straight to their house.
Yeah. And that was
Amazon, we could do a couple of larger ones.
Well, see, here's the thing. The advantage is I'm not with the budget that I get from UHC. It's not me spending the money. It was Chris and Kathy. They spend it. So, because then if it creates a different, or.
We'll need to let Julie in.
Yeah. Because I've never, it's not like the county's money. It's UHC, or UHC has that stuff too. We can say, okay, we
only want $30,000 and we want $2,000.
Yeah.
That you will ship direct to their house.
Yeah, because I asked Lori, I said, we need to start thinking about our swag item because we've done cups and bags and all that stuff. So if we're talking about engagement, right? And it's engagement and health. I said, do we have a book? So I'm almost thinking, yeah. Well, she said, no, there's not really a book. Just tell us what you want. Okay, well, the team, we're going to go through and pick out some items but then you also have to think, this may work out better because everybody will have a chance to get a swag item. All 1,700 people. And versus just the people that come, which is like 800. And then the prizes for stuff. So we just use the money differently.
Maybe we do a little bit smaller swag item.
Yes. Yeah. Yeah. So, and and then I'd mentioned to Lori that we would need, we're gonna, all this, for the new plan, just talking about that. So we would do it by webinar, which I think is, it's gonna work out. My concern is, like I said, Taryn, who wasn't here, and his people, and they want us to show up there and.
Well, and I didn't mean to throw him under the bus at the end, but I really wish he was talk about engagement. Like their hands up. And he never got back to me. I told him, I said, call me.
Usually if he's on vacay, he'll have Kelly.
Oh, no, I'd be shocked if he was. Then Bob would have told me.
Yeah.
I accidentally had their numbers swapped on. I called Bob, trying to get Taryn, and I said, oh, hey, did I call you? I'm so sorry. I said, I'm trying. He goes, no. He goes, did you go off that contract? He said, yes, y'all's numbers are. So he's like, okay. I think he would have said, oh, he's in Bora Bora, or.
Yeah. So, yeah. So anyways.
Bring it back.
Yeah. And then she's the one that. Well, she would, if she did, she'd have to, yeah, we'd have to, we just renewed his term. Now think about, oh, I know I was, yes, so on the next agenda.
I mean, it would be.
Yes, he would step down and we'd have to publish the posting and do all that. But, oh, yeah, we could do virtual interviews.
To me, I'm like,
Oh, I know. On the next agenda, I am going to have agenda item on there. We do need to make the decision I'm trying to think of all those contracts we have to renew. We already know the RFPs. We extended it 2 times because he wasn't answering questions. I'm like, and so just so I pulled the team to say, there's some things, like I said, home survey, they can do a really good job, but it's getting to that point. Or a forward-thinking plan, and that.
And I like Morgan and I like Sean.
And Caitlin is, when we were on that call for the RFP, Shelley, don't talk down to me. I actually had already gone through, and John did a better thing. He put them all together, and
yes, that was great.
And then I went and I put the rest of the stuff together. So I have the big master. I haven't had a chance to look at the BAFO, but then I'm just like, what are you talking about? After you said, we sent it to you, said, this is our pick, what's your pick? It's like,
Email me those examples. Because when Morgan calls and says, hey, how are things going? She's done that once before, but it was back at the end of March, and at
yeah.
that time.
Hey, yeah, you met.
Yeah.
Yeah,
Here's the orders that we're still having.
yeah, they're just,
Yeah.
It's dragging.
Remind me about that wellness surcharge. I know we told them.
Oh, we've said it. I've said it so many times. Even in this, I was like, well, are we gonna get money? No. But their contract to the renewal will be on there. And so I'll put that as like right after the minutes. And then I guess we'll ask David not to jump on. Right. He shouldn't jump on the call until, yeah. And I'm thinking we probably don't want UHC on there until 9:30. I think, I know it's probably better. I think UHC is more organized. when they present. But the other thing I was thinking.
Why don't we just have our meeting with them of just the benefits committee? That way, because I'm worried someone's gonna get on early.
Oh, yeah.
So if you just send out a Teams meeting 9 to 9:30, and then we'll know.
I know. I was like that live stream thing. I'm like, oh, well,
I mean, we can see if someone else on.
yeah.
So we'll just make sure that they know to get on.
But anyways, his is going to be on there. Then I think then we'll have the finalization of the RFP. At this point, I, Blake said, oh, Symetra didn't send back a BAFO. And I'm like, did we give him enough time? Because by the time I outlined the questions and sent it to you, you sent it to them, then whatever, I'm like, but he did say that there could still be some things to finalize. I can't imagine they're going to know on, what is real important is the one, only adjusting rates during open enrollment. You don't need to be maneuvering those pieces, but rates, yeah, that's a bigger piece. So I think it was just an oversight. I really want to say it was an oversight on it.
Say we're in COVID-19, what's crazy. I'm
Mhm.
sure things are just crazy for them. So I'm trying to do that.
Yep.
Separate from the because I have some improvement. But the thing like the template, I mean, that's easy. Well, a surcharge we talk about.
Yeah.
I mean, that's not.
Those
that's
are
not,
just.
oh, COVID-19 is crazy. I can see the RFP being backed up a little bit because I'll give them the benefit of that. Those other two things.
It's just, and I know Caitlin's supposed to be, right? She's supposed to be the account manager. And I don't view her as, well.
No, to me, David's the account manager.
That's what I was thinking. That's the way it, yeah.
Because otherwise, why wouldn't we ever talk to her? Like, I don't ever talk to her.
Yeah. Well, I just, because, yeah. She's nice. I mean, but sometimes it's just like, whatever, just, this is what we got to get done. And it's not like I don't tell you about it in advance. So that's just fine. But I don't know which direction Judge is going to go with them. I think we put in the budget for 5%. Oh, but I don't know that he added compliance fees. We've been asking them, hey, what's the PCORI fee that, remember, you didn't tell us about last year? Now it's back this year. What is that amount? I think we finally got an email back from them, right, Suzanne? It said, yep. Okay. Yeah, that's probably what I think we're going to do here. Okay, so I will try to get us connected with Rory and say, hey, guess what? We now need to put this plan together and put some costs together. Let me see if I can call him. I gotta send that. Yes, that was the directive. Okay. It was, would we need new bomb guard license? Bomb guard, is it BARGD or BOMO? B? Okay, I spelled it right. Bomb guard. departments. Team. Employees. So any funds needed to have a virtual benefit. Yeah, I'm thinking we wouldn't have a lot of benefit vendors for the virtual benefit fair. But then I think we're just gonna have to pull up, let's get some ideas on what we'd want to do for a swag item. Maybe it's more on, maybe it's a package on you and the employee keeping safe. Like, I've seen some companies have been sending out like care, like this one person, she actually works for an IT company. Her company's been sending her care package. She got like hand sanitizer also. And the next day she got a fruit basket. She was getting, of course she works for an IT company, all this different stuff. He wanted these so he could place, I heard next Tuesdays, on next Tuesdays. So let me know time we can brainstorm to prepare. So, yeah. Then Holmes Murphy says, oh, we can put together a communication plan. Great, you do that, right? Jump right on. Let's do it. That's the problem. We're going to have that pretty quickly. So we're going to have to start working on that. Well, they have to, yeah. Yeah, I'm like, ooh, have not heard of that. I know one employee asked for, he wanted us to provide a list of dentists for him. I didn't respond to that yet. I'm like, yeah. For access. This person's, oh, did you respond to this one? She's a new hire. Emma, what? I'm a new hire and I tried to access benefits on Jehovah. When I click on this link, it gives me an error saying website is not secure and it doesn't even show me the login page. I don't know what that is. I don't know when she started. IMMA. Hello there.
Hey, Sally.
Okay, so we just wrapped up our benefit committee meeting. And Jay wanted me to connect with you. He said, I was mentioning to him that we had already had kind of a discussion about a virtual benefit fair. And the direction I got from the committee was we need to go forward with that plan. And, and so Jay wanted, I was hoping that maybe you and Jim or whoever, we can get together on some expected costs on both. My team needs the ability to be able to bombard in to help employees, that way that they can log on and we can see what they're doing and help them with enrollment. So I think Baumgart licenses, there's a fee for that. And then we don't have to have the whole list, but if maybe we can connect, I don't know if you need Jim or whoever, but that way we can connect to see what potentially costs we would need and what is needed to prepare for a virtual benefit fair. And then his hope was that we would get that to him so it could be included in next week's commissioners court. Now, I don't know how those costs are getting submitted, but Judge, I guess, asked for that and Jay asked for that. So I'm like, okay, I don't know what you're submitting, you know what I'm saying, on the IT side of things.
Okay.
So
no pressure, you know, Thursday by 12 o'clock to get all this information.
Oh yeah, no pressure, you know. So I guess, and since I'm not the IT expert, I'm like, well, what will I need to do this? So
I'll take care of it for you. That's not a problem.
Okay.
I'll get with Paul Holz. He can get me license numbers for Baumgart. The only thing that I need to know is how many licenses you think you'll need. Do you want to cover everybody for HR, or do you only want to cover a certain amount of people? It's totally up to you.
yeah, let me follow back with Rebecca, but I think she was just talking about the benefits team. So that would be just the three of us. But I will send her a message just to, hey, are we sure just us? Because I can't get Malia one because she's not full time, so I can't get her access into the portal to do that. So for that stuff. But anyways, but I'll check with her. But for now, I'd say 3 on that. And then I have no clue what type of IT technical needs are going to be needed for the virtual benefit fair. What I'm hopeful is whatever software or whatever we use to do that, that my envision is that when the employee goes in and they go through like the education room and maybe they go to see a couple of voluntary, you know, vendors or whatever we're able to get published or posted there. I don't know if any of the systems allow you to see who's gone through and who's completed it. And then
I think it allows you to do all of that. I'm trying to get a demo together for you.
Okay.
The one that I sent you in particular, I've used before through virtual conferencing and everything, and it is, to me, it's far better than some other ones. I've been going through one today, and it's like it has your keynote speaker, and it has, okay, you can look at this class, and then you can look at these 4 classes, and then you can look at these 4 classes this time, and you can look at these 4 classes at this time. That kind of gets boring and old.
Oh, yeah.
The one that I sent you is kind of I like it because you can set up a virtual map pretty much.
Okay.
And you can have vendors in certain places on this virtual map, and people can come and go. They can click on that vendor, and the vendor gets a notification that you're there, and if they have any questions, they can live chat with them, and you can put up videos and documentation and all of this stuff inside this vendor's, you know, booth. It's a virtual booth. And then when you're done with that booth, you leave and you can go to the next booth, and you can click on it and see if it's even applicable to you. I can't say that word very good. And to me, I like it. It's more of a visual experience rather than just just throwing stuff at people, just on a screen.
Yeah.
I kind of like it better that way, but that's just my personal preference.
Okay. Well, and that's good because what I'm hoping is that we can see who completed what. And then what we're hoping to do is whatever, benefit fair swag thing that people would normally get if they came to the event. My thought process is we're going to pick something that we can, once we can confirm that that employee completed, we would mail out to their home. You know what I'm saying? So it's like, hey, here's our appreciation for attending the virtual benefit fair, but there would be a couple of things that they would have to at least visit. You know what I mean? Like, especially with any plan design changes and rates, and maybe it's the wellness action. We create a wellness action corner or something like that. You know what I mean? We're able to identify that they've done those, and then that earns them their appreciation gift. That's what we call it.
So when one thing that they did have on the website, they were asking when we were thinking about doing a benefits fair. Do you have a time frame or a date that you are planning?
I'm planning our date of our benefit, our in-person one was October 28th. So I think we could still go with, that date. Let me, because open enrollment, we still have our dates set for open enrollment, which is, and I'm sorry, I clicked off my, I think it's like I think it's like the last 2 weeks in October, and then the benefit fair. So we could move, if it's going to be virtual, we could move that date up before open enrollment, right? That would probably, and then it could run all through open enrollment. Maybe that would be the plan. That might be a better plan versus having it at the end of October. You know what I'm saying? Because that way, because it would be a way for people to get informed and education too.
Sure. So, and then one last question for you. This is on a side note because I was popping in and out of just to make sure that your live stream was working. I have totally spaced on this. Is there a day that we have to have our physicals and all that stuff done by?
Yeah. Well, the committee, in fact, we've got to work on the communication to that. So I got a 1-month extension for the benefit committee. So it is normally November 30th, but we're moving that date to December 31st.
Oh, okay. So as long as you have all your stuff done before then, you're good to go.
Yeah. And I will tell you, my wellness exam was last Friday. I did a virtual, my doctor wanted to do a Skype, which was great because I didn't want to go in anyways. And so, yeah, so the only thing is I had to do my own height, my weight, my temperature, my blood pressure, which, no problem. I did that. And then I just have to go do my labs at the lab, and I have to make an appointment because I don't think they're just taking walk-ins anymore to the lab. So you just have to plan for that. But I like that option. It was much better than, I don't want to go into an office and get exposed to anything that I don't unnecessarily need to do.
I hear you on that. I mean, that's one thing that my wife and I were talking about because I think her appointment is coming up either this month or early next month, and she's like, "Do I cancel it? What do I do?" Because
we'll see if we can do it as Skype.
Going to be around.
Yeah. But a lot of the position, mine's a seat and provider, so that was what they were opting to do, which is perfect for me. So, and then, so that's what I know about that. So anyways, the date is getting extended. Now, we haven't communicated that out to the population, but we will, because we have to get it programmed into UHC, but I'll send out a communication to all employees as well.
Okay. Because I know we were talking, you guys were talking about sometime in like June or July. This was last year, and then it got extended to November and all this stuff. So I just wanted to make sure that I was like, oh gosh, do I need to schedule this like right now and get it done?
No, you've got plenty of time, but I would most definitely, at least even if you can't do it now, get it scheduled, but then ask them if they have that Skype option, if you can just, do a Skype visit and then go do your labs and then make sure you download that form and get that to your physician, and then your physician records your lab results on it, and then they send it in.
Okay.
Or you can upload it. You can do it either way. You can, but they have to complete the form and sign it, and then it either you upload it or they fax it.
Easy enough.
Awesome.
Alrighty, I'll get those numbers for you. I'll do tentative right now, 3 licenses.
Okay.
But I'll have him ask for up to 10. We'll just put that on there. That way, just in case you need the extras on there, we could do that. And then I'll let you know about the virtual fair when they get back to me. I might just call them here after my meeting and then let you know.
Okay, awesome. All righty. All right. Well, thanks so much for your help today. So hopefully next meeting will be, I think it'll be much easier. I'll know, because what was happening is Rebecca said, oh, get that live stream when I had signed on and send it out to the committee. And I was like, it's all through Agenda Click. And that's what happened. It went on to YouTube. And so that was the sound that we're hearing, right?
Yes.
Relay. Okay. Got it. Next time we know not to do that.
All righty.
Awesome.
Have a good one, and I'll send you that information as soon as I can.
Okay. Thanks, Roy. Okay. Bye. Yes. Yes. We're not. Yeah. I'm like, what are we the? Oh. Yeah. Like, see, and that's the part on my concern on the accountability part. So, yeah, I'm still trying to do the math, and even for the 500, even if they went to 750, but not my goal, right? Well, I mean, I just, so we're going to be competing against JP3. I didn't get Miles. Okay. And Sunday, actually. I could just leave these tables and chairs here. We're probably going to be the only ones on the 28th. So Lori seemed to enjoy her birthday. She was surprised. I didn't ask you, how was your Mother's Day? Did you get to talk with the kids? Yeah, they're like, we can't go anywhere, Mom. Jump up some miles. Yeah, we planted. We took the dogs to the park, and then we went to Lowe's, and we planted. Well, yeah, because Saturday I did. Oh, so what I'm doing for Kaylee's graduation is, I think, did I tell you they're not going to let grandparents? I sent an email. I haven't heard. So I talked to my daughter-in-law. I think my daughter-in-law's really, because it was Mother's Day and her mom passed. I totally forgot that. And because I said, hey, what are you doing? Oh, I'm sitting on the couch. And I know that Arch and the son, they were off doing some race car thing. And so what I'm doing for Kaylee's graduation is there's a shop in downtown Georgetown, and I got this old, it's a window, and it's about this big, and it's got 8 window panes. It came out of a house out of Waco. So what we're going to do is Arch is going to clean it up a bit, and fill in some of the, but I got to gather the photos. I'm going to take my photos and get them copied at Walgreens. And then I told her, I said, hey, here's what we're doing. Do you like this idea? You could tell people to surprise Kaylee. They could bring those that have known her since she's been little, bring goofy pictures of her. And, oh, I gotta go to Hobby Lobby. Anyways, to get the stuff to put the pictures on it, we can make like a, right? But this window is heavy. So anyways, so that was my idea for the gift. And then I think I told you, I stopped into that one shop and I ordered her just get a bag of goodies. Well, so then Lynette goes, she goes, oh yeah, that's good. I said, so can you reach out to those people that are coming? And I said, and you guys, I'm not sure, but I think you still need to be under 50 for any people coming to the graduation party. Because one set of friends, they're not coming, and they got 2 little ones, and that's why they're not coming. So anyways, so I was talking to her about that, and she said, oh yeah. Then she says, oh, did you see? We're kind of sharing the party. It's going to be Kaylee and Colton, the boyfriend. Oh, wow. Because the boyfriend doesn't have a lot of family here and stuff. I said, oh, well, then you can talk to his mom, and she can do something like that for him. I said, Kaylee will have it, or this will go on your wall, and then, or whenever Kaylee gets married, it's already ready. And right, you know how when they do weddings, they show that. So I said, well, because I'd asked Archie, I said, what do I get Colton? He says, oh, you don't have to get him anything. Well, now I kind of have to, because it's a Colton party too. And so Lynette says, well, mostly they, for graduation gifts, they just put a box of people put cards and money. And I'm like, well, that's not what I'm doing for Kaylee, because I got her a really pretty Kinder Scott necklace. It's a double chain thing. And then I spent a good penny on getting her a bag and engraved, and then it's those big things you see and put your keys on it, getting that initialed, engraved. I got her another necklace. I got her a Hutto Hippo candle. I'm getting all kinds of different stuff to go in there. And but when Lynette said that, oh, well, most people just do cards and money. I'm like, oh, well, this is not most people, and you know. But so I'm like, oh, great. Now I got to get a card and I guess money or a gift card probably in there. But I didn't know it was going to be like that. So I said, you know, you do have a across the street from you. You might need to be careful on how many people you're having over. And they didn't even think that. So now they're, you know, because they were going to do briskets and all this stuff, and now they're having a hard time finding briskets. So I'm like, I know. So I'm like, just saying, you know, or if you're going to have people over, because they have their pool is probably from that wall, but they got a big above ground pool. And I said, you just might want to be thinking because you don't want the party interrupted. I don't know that they're doing that, but you just don't. But surely they're going to know, like they're going to celebrations going on. So they're doing, somebody's put together a parade for the kids this Saturday, this coming Saturday. And I'm like, great, it's supposed to rain. Rain is coming. One of the other moms. So I told Lynette, I said, I sent her the copy of the email that I sent to the school. And I said, did you see my email? Yeah. Why don't you engage in getting the parents together? Oh, I guess I could do that. Oh, I could email the principal. Yes. You know, because it's like Bubba's mom can't go, and I know other parents that have got, they got kids. Yeah, and Rory said they got a smart IT person that can do it. I mean, it's a live stream. They do stuff for football games. So why can't you? And that's where the graduation is. And honestly, I'm fine with live stream. From sitting out on my patio, drinking. Yes, and you people can all be there in the crowd. That's the way I see it. And so, but yeah, so, but then I picked up on, I told her, she said, yeah, she sounded really down. And then I thought about it. Oh yeah, tomorrow's Mother's Day. And, you know, with her mom passing just right before Thanksgiving, it's like, this is the first year, you know, I was like, oh, so this is probably not, and I don't know what they did because we were busy all day yesterday planning all that stuff. So we planted, well, I went and got 6 more lily plants. They are, I just love them. They are a really pretty orange one. And I got another pink one, yellow one. I went to a different nursery. I will. I'll send you some pictures. And then I got this. I got two new tomato plants. Yeah, I didn't take a picture of the new. I will. We put the lilies, and then I bought another. This one's a pink jasmine. Trying to get it to grow on the fence, and then I finally got Arch to decide. We had bought this planer wall thing. We haven't done anything with it yet. So what we're going to do is make it where, I got the neighbors behind me. So I'm going to kind of stand it up, and then I think I'm going to get a bougainvillea, a couple of them to grow on it. But at least he finally agreed. Oh yeah, we could put it in front of the shed. I'm like, at least it will block a little bit that way. Nothing to look at a building on equipment, but so that's what we did. We did. yard all day. Oh yeah, I mowed. That's what we did. But it's supposed to rain, I think, like starting I think tomorrow. Every day is supposed to rain then this weekend. Or did it change? Oh, yeah, wonderful. No, I don't want that. Oh, was he back down there again? Oh, okay. But that he has to drive back and forth every day. Oh, this is. I had to go by that one woman's house and get my stuff that I ordered. Oh. Did you see that message from Malia? You can scan directly to the network drive from the main. Click scanning. It says click scanning on the copier main screen. In the top left corner, click on scan to email and press to folder. Oh, that's awesome. Then that, instead of her sending that stuff to your email, is that what she's doing? Is that working out much better? Well, no, but even if she gets a scan into the folder, then you can always go in and open it. Yeah, but then that way it's not junking up your email. Oh, okay, good. It's in there, good. And perfect. I think that's gonna, I was just reading the email about the child care watch. I think that's gonna be an issue. What's my surgery? Was it Rosemary Cooper about the vision?
Yeah.
I she yeah. He is diabetic, but he's wanting to go to the. I shared that with Miranda because Miranda responded to her. You have to watch. He goes to an ophthalmologist, which is on the medical side, and he wasn't in the vision plan, so they wouldn't pay for that eye. No, well, I don't. I'm guessing she enrolled him in vision, but last year, remember, vision wasn't separate; it was just separate this year. But he was going to an ophthalmologist that wasn't in the vision network, so she was upset. The exam wasn't paid for, and it was the way he coded it, for that it wasn't like a normal eye exam. So that was the problem. So I don't know what. Now, okay, so she's probably already reached out to Miranda because Miranda and I that was last week. So, yep. Which is not going to show on the vision side, it's going to show on the medical side. Because the provider, he's not. And honestly, she does the, did you hear Rob on the call at all? I think why is Rob on this call? Who is Robin? What is he doing there? So this person now wants to stop her dependent care stuff. I'll let you reach out to her. She's on the list. She responded. Janessa Stevens. Yep. Yeah. No, you weren't. She didn't send it to the vote, so she sent it to. So we are not. Well, for dependent care, I mean, I just hate that she missed it. I wouldn't go backwards. Yeah, if that's what she wants to do. Yeah. Yeah, because we can't go backwards. Interesting to see what happens with the. How many people do enroll in the HSA? Wish it would have been a better option for me. I need to get. Speed's looking for a deposit form. From sitting all day, used to standing, and then Katie comes and we go for a walk. So. Oh, I think you're just sending her a blank form. Yeah. And then she's gonna, yeah, I would say if she sends it back, you could send it to her. You'll need to. I wouldn't want to. It'll be interesting to see if David built that budget based off surcharges. And how many times do I say it?